The country to share their knowledge and vast experience with our audience. I also welcome all the audience, online and offline, who have joined us in this offer-day CME on the theme Brain Injury Rehabilitation Recent Advances.
Now I invite all our guests, Director Sir, our guest of honor, Professor S.L. Yadav Sir, Professor Anupam Gupta Sir, Professor Anil Gupta Sir, Koustubh Chakrabarty Sir to come on the dais and do the lamp lighting ceremony in front of Devi Saraswati. Please, sir. Achha.
Devi Saraswati, the goddess of knowledge, the one who is a symbol of purity, harmony, and divinity. Requesting the guest to take over the dice.
Now that the invocation part of the inauguration is over, it will be now my pleasure to invite our guest of honor, Professor S.L. Yadav sir, to express his views about the CME of the department in front of our august audience. Thank you, sir. Please.
And thank you, Dr. Jaideep. Respected Professor Nitin M. Nagarkar, Sir, Director, AIIMS RAIPUR, Dr. Jaideep Nandi, Dr. Ronak Kumar, dignitaries of the dais, and distinguished speakers, Dr. Anupam Gupta, Koustubh Koustubh, Dr. Anil Gupta, faculty from other departments, students, ladies and gentlemen, very warm good morning. It is a great honor for me to be talking with you today on this exciting occasion. Also, I am delighted to have the opportunity to address such a talented gathering of AIIMS RAIPUR. I am very happy to be sharing, and Director Sir will be agree with me that we have made no mistake while we selected Dr. Nandi as AP few years ago. Under his dynamic leadership, really PMR department took a shape and bring to such a newer height where there's innumerable academic activities and achievements in the department, which we witnessed this morning while taking the round in the department. The only premier institution in the region to cater the differently abled population, which are doing excellence works in this state of Chhattisgarh. This, of course, would have not been possible without the blessing of Director Sir. I believe this is second in row that the PMR department had arranged CME on TBI rehabilitation and recent advances, which is often neglected, poorly addressed, and need of the hour to care such subset of population as good care made the increased survival, but with the various disabilities in the TBI cases with varied domains and needs multidisciplinary care almost forever. So you have chosen the right subject this time to discuss as in a CME program. I hope that participant will benefited out of these half-day long deliberation in the direction of better comprehensive management of traumatic brain injury patients to an extent to reintegrate back such patient into society as a useful, productive member. I wish a great success to this CME program. Thank you. Thank you very much.
Thank you, Professor S.L. Yadav, sir, for your blessings and guidance as always. Now we'd request our chief guest to felicitate our guest of honor, Professor S.L. Yadav, sir, with a memento of honor. Thank you, sir. Now I would request our chief guest of the occasion, Professor Dr. Nitin M. Nagarkar, sir, to bless the occasion with his few words of wisdom. Please, sir.
Thank you very much, Dr. Nandi, and good morning and warm felicitations to everybody. Thank you very much for attending this hybrid CME, Brain Injury Rehabilitation Recent Advances. Dr. Nandi, like sir has rightly mentioned, has been the key person and the driving force behind the entire department, the various range of activities which sir you've just seen, whether it's the OPD, the IPD, the other services in terms of providing orthosis and the workshop especially being made ready, and of course now post-graduation and teaching and training. So thank you very much for gracing the occasion, Professor S.L. Yadav. We have interacted many times in the past and we gain a lot from his experience, and I'm sure the department will continue to get your guidance, sir. And thank you, Professor Dr. Anil Gupta, Professor Dr. Anupam Gupta, Dr. Abhishek Srivastava from Kokilaben Hospital, Dr. Koustubh Chakrabarty. So thank you all of you, and Dr. Navin from NIMHANS again. So thank you for gracing the occasion, coming here physically. And I'm sure that the ideas that you will give to our dynamic young team is not just restricted to the CME, but will have definitely much more far-reaching advantages. We also have Professor Vikram Pandit, who's the Professor Pandit, who is the head of the Department of Medicine over here, Dr. Ronak from this Department of PMR, and other faculty members and staff and residents and my dear students. So thank you very much for all of you coming and gracing the occasion here. We all know that India has a huge burden of various diseases, and many of them catch the focus, and many of them are gradually getting the attention of the public or of the ministry. But I think we now all are aware of the huge population that we have and the huge disadvantaged population which needs to really get this kind of service. I think institutions like AIIMS have been set up with this very purpose. They are, of course, to look after patient care, but teaching, training, and research focused into these areas, in these neglected areas, which must have been in the past, but I'm sure the days are now changing. We have the resources, we have the trained human resource also now, and the government of India, as well as the state government, plus the NGOs, are all, I think, working together in tandem now to provide the best possible services. So I think the CME is a great step forward, and will continue to do so in future. I think by the next time when you come, or the years later when you come, you'll be able to see the expansion of the department also. So thanks very much. I'm sure that everybody is going to gain a lot from today's discussion. Thanks.
Thank you, sir. Now, I would request Dr. Jaideep Nandi to felicitate Professor Dr. Nitin M. Nagarkar with a moment of gratitude. Please, sir. Thank you, sir. Also, we take the opportunity to felicitate our organizing secretaries. Now, I would request Dr. Anupam Gupta, sir, to felicitate Dr. Jaideep Nandi, sir, with a memento of gratitude. I invite Dr. Anil K. Gupta, sir, to felicitate Dr. Raunak Kumar, sir, with a token of gratitude. Thank you, sir. No.
With this, we move on from the invocation part of the inauguration ceremony to the scientific session. Now I request our guests to take the audience, and we will clean the stage and start the program with keynote address of our director, sir, Professor Nitin M. Nagarkar, regarding the relevance of today's CME. Thank you, sir. So we are starting our scientific session of today's CME regarding brain injury rehabilitation recent advances. Our first speaker will be Professor Dr. Nitin M. Nagarkar, who is our guiding light in this institute, who is the director and CEO of AIIMS Raipur as well as AIIMS Bhopal. He is a professor and head of Department of ENT, Head and Neck Surgery of AIIMS Raipur and AIIMS Bhopal. He had more than 25 years of experience in the field of ENT, Head and Neck Surgery. He had 6 orations and many major awards. Regarding his special interest, it is related to oncosurgery and laser surgery. He had more than 80 articles indexed in international and national journals. He was an examiner in various universities for UG and PG examinations and PhD. Today he will be talking about brain injury rehabilitation, necessity and relevance. So now it is over to Professor Dr. Nitin M. Nagarkar. Please welcome him with a round of applause.
So thank you very much for the kind introduction, Dr. Nandi. I will just be speaking briefly because I think we've got many stalwarts here. So this is just an overview of brain injury rehabilitation necessity and relevance. It's more for the laypersons and general people, but I'm sure that the experts will deliberate and go into the details of all this. We all know that worldwide it's a major issue, traumatic brain injury, and it's a leading cause of death as well as disability worldwide. And more than 7 lakh patients who require hospitalization for TBI in Europe itself. And there's of course a variation a bit of age and gender across various geographical regions. And we can also have the mild, moderate and severe varieties of traumatic brain injury. And this is more or less so across the globe, whether in the US or Europe or Australia, Asia. The majority, approximately 80% of the traumatic brain injuries of the milder nature, but about 10% moderate and about 10% severe traumatic brain injury. Of course, that requires much more treatment, hospitalization, and further rehabilitation. So if we see the relevant statistics, a total 2.8 million traumatic brain injury related emergency department hospitalizations and deaths also occurring if you add everything together. And of these 2.5 million are related visits to the emergency department, and majority of these are milder ones. So if we can see the bulk out of 2.8 million in the US, 2.5 million are milder, and that leaves only about approximately 3 lakh patients who require hospitalization. So the bulk would go to the emergency department and possibly get discharged from there. But a fair number would require hospitalization. And of that also around 56,000 patients die. So that's a fairly large number even in the US. And so many would be then left with long-term disability. So in the US, 40% of the hospitalized as a result of the TBI, they will report some sort of ongoing issue a year following the injury. It doesn't stop over there. So something continues to happen and the patients would still require some sort of a treatment even subsequently. And improvement in memory and problem solving, these are listed as the most frequently unmet needs. So not that, because it's a diverse management, multidisciplinary, like Professor Yadav just mentioned, but so many things which persist, possibly related to memory and problem solving, apart from so many others. And the CDC in the US estimates that at least 5.3 million Americans they will currently require long-term or even lifelong assistance of daily living, ADL activities as a result of this injury. And many of them are possibly younger or in the, that dynamic age, 20s and 30s when they're running. So for them, it's a huge economic cost also. And in the year 2000, the economic burden of the TBI, this traumatic brain injury, in terms of the medical costs and lost productivity in the US, totaled an estimated $60 billion. And this is the year 2000. So if we continue and extrapolate, I think the number of accidents, especially in the developing world, have continued to increase. But yes, we also have the Indian scenario, and I'm sure that all the stalwarts are aware of the NIMHANS study by Professor Gururaj, and then subsequently so many other studies from other centers too, and estimated 1.6 million who suffer from TBI every year in our country. And I think many go unreported because this is a very large country, diverse, and approximately 0.2 million, which is again a big number, succumb to die because of this traumatic brain injury. And 1 million, so 10 lakh patients requiring rehabilitation service at any given time. Again, that's a very large number. And as I said, many of the far-flung and remote areas, we don't even know how many more unreported cases are there. And of them, the majority would be classified as through severely injured in road traffic accidents. And 76% have suffered head injuries during these severely injured road traffic accidents. So in India, the major cause remains road traffic accident. And the fatality rate is 70 per 10,000 according to some reports coming up, which is much higher than in the developed countries. Even in China, they have been able to reduce their mortality rate following road traffic accidents, and in many of the Asian countries as well. And I think that's where, when we discuss about traumatic brain injuries and their management, their prevention is also extremely important, because then the bulk of the disease would be lesser. We'll be able to handle our cases also in a better manner. And alcohol, of course, like in most other countries, even in the developed world, contributes to approximately 20% of these injuries then. And then in severe TBI, like I mentioned, about 10% are severe. In that, the mortality could go up to 30-40% as well. So the cause of the brain injury varies in the country, whether in the low and middle income countries, whether in India also we are talking of. It's mainly the road traffic accidents. I think that's even trauma specialists, neurosurgeons, and PMR specialists will all agree that the road traffic accident causes the bulk of these traumatic brain injuries, rather than military conflicts, child abuse, and so many other causes as well, including falls. But in the US, because falls are more common, especially amongst the elderly, sports injuries, road traffic accidents there as well. But gradually they have been able to, I think, curtail their road traffic accidents. I think time has come for us also to take those steps. And the government of India is, I think, seized of this matter. And repeatedly, we are also trying our level best for that. So whether it is because of a penetrating head injury, because of drowning and head injury, closed head injury in a vehicular accident, or traumatic encephalopathy in boxers who repeatedly have the trauma to the head, or following ammunition and shelling, so different types of injuries. So this is a Rancho Los Amigos revised scale for recovering following the brain injury, and there are 10 levels. It's a very simple and straightforward scale which can be utilized by anybody, I think, who deals with these kinds of patients, starting from level 1 to level 10. Level 1, obviously, there's no response of the patient to anything, to any stimulus. And if you see gradually generalized response, localized response, confused, agitated. And then if you go to the higher levels, that at level 8, it is purposeful, appropriate, and the patient is able to stand by assistance. At 9 level, appropriate response, purposeful, will be able to stand by with assistance at request. And level 10, purposeful, appropriate, modified, and is independent enough. So it's a gradually, I think, very practical scale which can be utilized by everybody then. So what are the associated problems after TBI? The list is long. We cannot cover, I think, in a short duration, but I think everybody should know whether it's related to the neurosurgical aspects, hydrocephalus, whether neurological, or whether related to orthopedics or brachial plexus injury, and then urological bladder. So it's a diverse, you can see plethora of symptoms which are there. And I think people who deal with these kinds of patients are going to come across all kinds of this presentation in whichever way, especially in a long-term management. And this would actually entail a multidisciplinary management of these patients to sort out these kinds of problems. And just to get some inspiration from some centers doing excellent job, whether it's the Shirley Ryan lab in Chicago, or the Spalding lab in Boston, or in Houston, Texas, the Memorial Hermann lab, the Kessler lab in New Jersey, on Washington, the Mayo Clinic in Rochester. I think some of these stalwarts have visited these also, the Shepherd Center and the Rusk Center in New York. But not that we are not doing. I think the Indian scenario has been changing. And I think as sirs you have witnessed today, we are also, I think, on that path of progress. And 22 states and union territories have a formal PMR department, which is now looking after these kinds of patients. About 49 medical colleges now have PMR, and I'm sure that number is only going to increase. And there are such setups, more than 100, even in the private and corporate sector. And from Koklabin also, sir has come today. So I think everywhere work is being done for spinal cord injury and traumatic brain injury patients. We are happy that almost 100 PMR residents are now passing out and doing their MD. We also have the program for junior residency, senior residency, and I'm sure that we'll keep on scaling up on future. So I think the key is a trained human resource at all levels, which can then go, because ours is a large country, and there are swathes of, territory which with very little of that human resource available. But the problem is there. I mean, these kinds of patients, even in the remote areas, you have fall from the tree and so many other issues are there. And then they also require proper management. There's just a map showing some of the hospitals in the government sector as well as in the private sector which have come up. And I think almost all of them have been doing excellent job, and they have been able to produce the human resource as well. I'm sure that everybody is contributing, and I can see some of the finest institutions here. I would even imagine that AIIMS Bhopal as well as AIIMS Raipur will be continuing in this particular direction. And as AIIMS, I was discussing with Professor Yadav also, that it is development of human resources, again, very important in our mandate to produce research relevant to this part of the country. And of course, patient care, which goes automatically. So all these things go hand in hand. And at the same time, we'll produce the trained resource, which can then serve in different parts of the country. But there are newer technologies which are available. I'm sure it would be discussed in today's discussions and deliberations, where new technologies are being adapted and they are utilized for the benefit of these kinds of patients of TBI and bringing new hope. Robotics has really helped a lot, and electronics, I know, even in our country, robotics has been given a boost by the ministry. And these are electronic computerized systems, mechanical devices, which will actually take over or support the human function. So basically, it's an attempt to leverage the principles of neuroplasticity and improve the quality and movement and increasing the intensity of the repetition of the task. And it can also evaluate the progress which is going on. So the degree of freedom which can be assessed using the robotics, whether for shoulder or wrist or the use of the Android robo. Similarly, upper extremity robotic devices, the BiManuTrack, the MIT-Menace shoulder elbow robot, in motion wrist robot, and so different types are now available. Mainly, you can see there from the US, and some are from Europe. So many of these have been coming up. Similarly, for the lower extremity, also there is a treadmill which is available, robotic based gait training, and you can do more longer programs and intensive programs using the robotic device along with a single therapist and the patient walking activity. You can also keep on assessing, the patient keeps getting the feedback as well. So this lower extremity robot is basically for the training part, for the gait, but you can also use it for the walking purposes. And for this, the Israeli company is there, Rewalk Robotics, which has produced this device. Similarly, Bionics from US also has a device. And I think virtual reality has been coming up in many fields, has come up in the Department of PMR also. And especially we also use it in ENT for the balance disorders. So I think the same principles to improve the balance and gait in brain injury patients. Even I've used it, it gives a very interesting feel. So I think you can try it for yourself even in our lab, and you'll see how the patients get trained. So gradually, it's a very gradual process, but I think it definitely helps in the rehabilitation part of these patients. We continue to say it is a team effort for these kinds of patients. Same thing in the virtual reality lab for the rehabilitation, adaptation and habituation programs. These are all very helpful. These might be costly, but I think finally there's a lot of advantage over a period of time because many patients can be benefited. Similarly, the neuromuscular electrical stimulation applications have come up, and there are many such which can be used for different parts of the body. Like, for example, it can be used for foot drop, it can be used as an aid for walking, a wireless heel. So different parts of the body. This it's again FDA approved. At least in the US, it is available. I'm sure across the globe it would be. Hyperbaric oxygen therapy has remained a bit controversial. In certain studies, they have shown some improvement that once the hyperbaric oxygen is given, it improves the tissue oxygenation and cellular metabolism, and also has anti-inflammatory and anti-apoptosis and angiogenesis properties. But I think it remains controversial, like so many other applications of hyperbaric oxygen still is not yet, I think, the standard of care. So the role of the PMR is broad-based, considering the needs of the patient. You have to understand the bigger picture of the patient, the needs of the patient, assess prognostically, and of course it is a team approach always, whether it's the medical management, which is focused on the management of the agitation, speech, the mobility, memory, and medical complications, especially which might require for the spasticity, Botox injections, cognitive issues, and as I mentioned, the bladder bowel, the issues that the patients have. Then, of course, the orthotic and assistive devices, neuroplasticity management, along with so many others that we just discussed, including robotics, and so many others have been tried. Maybe it's still in the realms of research, whether it's oxygen, hyperbaric oxygen therapy, stem cells, and so on and so forth. But occupational therapy, prosthesis and orthosis, and physiotherapy remains the core. And I think all the hospitals which are dealing with these kinds of patients definitely would be doing that, whether for the ADL, first of all, occupational therapy for the activities of daily living. We have our room also specially designated for that. Dr. Nandi showed that today for dressing, eating, bathing, and then the advanced, the instrumental activities of daily living, where one step further the patient can actually start moving around the house, helping and doing more work than just looking after himself or herself. Assistive devices, education, innovative, different types of splints are available again, manufactured by different companies. Similarly, I'm happy that we also have our own workshop over here for the prosthesis and orthosis. These equipments are being given. So whether it's ankle foot or whether wrist hand or knee ankle foot orthosis, these are available here. Then powered wheelchairs and standing frame stair lifts. So many things are there. Physiotherapy for range of motion, strength, spasticity, coordination, balance, and all. I think we've got a wonderful team which provides this kind of service. So again, if you see broadly neurosurgical, neurological management, neuropsychiatric issues, and so if you see, the range is so much, whether we are talking of seizures or strokes or encephalopathies. So it's a team approach. Here you require the psychiatrist, the neuropsychiatrist, you require the neurosurgeon, the neurologist, and of course for the various management, again, you require the further management of ophthalmologist and the ENT and the speech therapy team also. The ophthalmologist again for the vision part, and your ENT team for the speech, language, and balance disorders. So I think we can all work as a team and look after these patients. There is definite evidence that there is effectiveness of this kind of therapy. And there was one study, the RCT, on 125 military personnel. This is from the US. And they showed that there was an overall benefit of in-hospital cognitive rehabilitation for patients with moderate to severe, similar almost to home rehabilitation if we can train that. But that is mainly for the moderate to severe. Mainly for the very severe who are unconscious, it is hospitalization which is more important in the early period. And I think once that period is over, then they can go home and get the home rehabilitation. Similarly, there is evidence of the effectiveness of brain injury specific services. And there are many studies, James et al. And Powell et al. And Zhu et al. And all of them come with that evidence that supports the impact of comprehensive system of care for the DBI patients, particularly in the post-acute period. So that's, I think, a very vital period where the multidisciplinary team approach is required. And these patients will definitely gain a lot. There's a lot of improvement if we act during the post-acute period. There are unmet needs like we just discussed, the social support system, the friendship circle, educational and pre-vocational and vocational support, because like sir mentioned also, finally we want them to go back to meaningful activity in their life, in their family, in their work. So community support and mobility is required, that there has to be special support by the government for that, especially during transport. And the loss of independence in ADLs has to be taken care of as early as possible. The ADLs should be back again for the patient. Sexual relationship is again very important because of sexuality issues, impotence. They have this feeling of that the attractiveness is less or inability to find a partner and develop interpersonal relationships because of their emotional issues. Similarly, there are medical legal issues regarding taking the financial decisions or engaging in any vocational pursuits or taking medical decisions, informed consent. So obviously they'll have to rely on their family members who will have to take these decisions. And there are dramatic issues like, especially in cases of minimally conscious or a vegetative state, naturally there is a medical legal issue, the patient cannot take a call, and I think the forensic experts know about that very well. So I think basically we should all work together and try to provide these comprehensive rehabilitative services for our patients of TBI. And like I'm always an optimist and I see the sunshine always. तो एक उजाले की ओर हम बढ़ेंगे. We'll all work together as a team and provide the best services for our patients. Thank you very much for patient listening.
Thank you, sir. Thank you, Professor Nitin M. Nagarkar, sir, for your wonderful speech that basically highlights everything that is going on regarding neurorehabilitation of a traumatic brain injury patients or brain injury patients as such. Basically, it is like a rocking ship which is being handled in the turbulent waters. We might have to deal with all the happenings in the ship during the stay in the sea, but we have to manage it anyhow so that we can safely take the patient to the shore to take more further expert help. Before that, we have to tackle it ourselves with our teams. So now I request Professor Anupam Gupta sir to felicitate Professor Nitin M. Nagarkar sir with the certificate and the gift hamper. Thank you, sir, for your wonderful speech. Our next speaker is Professor S.L. Yadav sir, who is working in AIIMS New Delhi since last about 25 to 30 years. And he is also the past president of our national organization, Indian Association of PMR, since 2015 to 2017. Next, just back to that. Or upar? This one. He has also work experience in SMS Medical College, Jaipur, and he worked in AIIMS New Delhi since 1990, and previously he held the post of IAPMR president. And his innovation and interest areas include modified flow reaction orthosis, phenol and botulinum toxin injections, spinal injection procedures, EMG, NCV, neurorehabilitation. He had also been WHO fellow, also been involved in spinal cord injury, E-module generation, and he is also a member of various prestigious organizations like International Spinal Cord Society, World Federation of Neurorehabilitation, and other organizations. Now I welcome Professor Dr. S.L. Yadav sir to tell the august audience about cognitive issues that are happening after brain injury. Thank you, sir.
Slide. This is forward. At the outset, I thanks Dr. Nandi and his team for inviting me to deliver a talk on the cognitive issues after brain injury and few of the recent advances. In next couple of minutes, I'm going to cover all these aspects because this is a huge topic, so I'll just be briefly touch every aspect on the subject. So the agenda of my talk would be that what is the cognitive rehabilitation, who gets the rehabilitation, cognitive rehabilitation, where does cognitive rehabilitation take place, and who are the providers, service providers, and what are the strategies for the cognitive rehabilitation. So before I begin, I would like to make a statement that cognitive impairment is a common consequence of traumatic brain injury and a substantial source of disability across all levels of the traumatic brain injury severity. The differential diagnosis of post-traumatic cognitive impairment is broad, which include emotional, behavioral, and physical problems. First line of treatment of these impairments are non-pharmacological treatment, which include education, realistic expectation setting, environment and lifestyle modification, and cognitive rehabilitation. And there is pharmacotherapies for the immediate post-injury period and during the subacute and the chronic phase of the traumatic brain injury. The question comes, what is the cognition? Cognition is a term which refers the mental processes involved in gaining knowledge and the comprehension. And these cognitive processes include thinking, knowing, remembering, judging, and the problem solving. So important is the problem solving, because until unless we know everything and we really aren't able to solve it, then there is some cognition deficit. And this also includes the higher level function of the brain, which encompasses language, imagination, perception, and the planning in the traumatic brain injury. So this is the cognitive process, which include attention and concentration, the processing and understanding of the information, memory for recent and the past memory, the planning, organizing and assembling, and monitoring and watching behavior to ensure the socially acceptable behavior, which also includes the communicating thoughts or ideas in way to who others can understand them easily. So it is a systematic program of intervention designed to improve cognitive abilities and the application cognition for everybody, everyday functions. And these interventions may reestablish or reinforce previously learned skill. Either the new skill can be learned and they could be reinforced on the already learned skills. We develop compensatory strategies for cognitive deficit and facilitate adaptation to irremediable cognitive impairments. So cognitive rehabilitation includes general intervention as well as the cognitive domain specific interventions. So in every TBI patient, this need to be tailored as per the need of the person had the injury of the brain. So these are the deficits which commonly seen after the brain trauma: the attention, which include alertness, selective or sustained attention, divided attention, change of focus, or hemi-neglect, which generally affected in 80% of cases subsequent to the trauma, where the memory is affected around in 65% cases with the working memory, phonological memory, etc. Executive function is very important before to arrive on any decision, which is also affected more than around 75%, which includes reasoning, planning, judgment, mood, and empathy following the traumatic brain injury. Then other deficits are the visuospatial and the visual field defects. So cognitive rehabilitation take place right and the acute setup care hospital, inpatient hospital, skilled nursing facilities hospital, outpatient rehabilitation services in a whole setup. So this has got importance in all kind of setup right from the beginning until patient is discharged in the community. These are the list of people who really provides the cognitive services, which include rehab physicians, occupational therapists, physical therapists, language and speech pathologists, neuropsychologists, and other healthcare providers to the traumatic brain injury patients. And always there is some characteristics to have the intervention for the cognitive rehabilitation program is structured. This has to be systematic, goal directed according, and it need to be customized for the every individual of the trauma involved, which involves learning, practice, social integration, contact, and should be in the relevant contact. But the repetition is an important key thing, which really emphasize again and again to achieve all the goals of the cognitive rehabilitation program. These are the key concepts that cognitive rehabilitation is a treatment for cognitive impairments related to traumatic brain injury. Neuropsychological assessment is a foremost important thing for cognitive rehabilitation, which consists of diverse interventions and should be effective regardless to the length of time since the injury and the injury severity level and cognitive rehabilitation need for the improvements in cognitive and psychosocial functioning. So these are the goals, like to enhance capacity to process and interpret information and also to improve ability to function in all aspects of family and the community life. This is the evaluation model. This has got 6 essential areas to test, which include orientation, attention, visual processing, motor planning, cognition, and that depends ultimately to create the action or response to have the good activity of daily living, go back to the walk, leisure activity, and the playful activities after the good cognitive program. These are the assessments tool to do the cognition assessment. So list of tools are there, and there about all the domains. They're like neuropsy is for the orientation, attention, language, and memory, where the token test for the language, comprehensive language. Inconscient card sorting, the abstract reasoning, concept formation, and mental flexibility, and so on. So important is like when to begin cognitive rehabilitation and what exactly to be done in the cognitive rehabilitation. So after diffuse axonal injury, 9 months after the diffuse axonal injury, the initial cognitive assessment to be done. And from 0 to 12 weeks, intervention of phase 1 is given, where with the objectivity of sustained and selective attention and visuospatial ability development. In week 13 to 14, the intervention or organization of learning and execution functioning learning to be done. And after the 15 minutes of traumatic brain injury, the post-intervention assessment to be done to reevaluate the cognitive deficit after the intervention, and then it should be re-emphasized for the better outcome following the traumatic brain injury. So these are the general intervention, like comprehensive holistic neurological rehabilitation is recommended. The treatment approach encompasses cognitive rehabilitation, discipline-specific therapies, as well as individual and group therapies directed to metacognitive, emotional, interpersonal, and functional skill, which I had already explained. Now we come to the pharmacological management of the cognitive dysfunctions. Pharmacology treatments, they are adjunctive to the non-pharmacological interventions, and these medications are beneficial in potentially beneficial in many ways, but few studies say that there is a limited evidence to support general treatment recommendations, whereas the pharmacotherapies have demonstrated promising outcomes if the studies is well designed. The molecule amantadine is a MAO in uncompetitive antagonism at NMDA receptor complex through the phenylcyclic binding site inside the receptor associated ion channel, which antagonizes the glutamatergic inhibitory inputs with presynaptic dopaminergic neurons, secondarily enhance the dopaminergic neurotransmission. So treatment with amantadine is improve the arousal following the 1 week past following the injury. Usual dosage are between 25 to 200 milligrams twice a day. Other molecule is methylphenidate, which augments cerebral level of dopamine and norepinephrine. And it is, class 1 evidence that it improves hyperarousal. Also, there is a class 1 evidence that it also improves the attention processing speed. But general cognitive function improvement, there is a class 4 evidence. The dosage is given between 20 milligram twice a day. Then bromocriptine is directly act on presynaptic D2 receptor antagonist. It improves executive function. Again, there is a class 1 evidence for this, and also improves cognitive initiation in the people who have got the diminished motivation or apathy in late cases of the post-injury period. But evidence is class 4 in this category. The evidence of bromocriptine on arousal among persons with disordered consciousness is inconsistent. But if you compare with the amantadine, bromocriptine also keep a place as a second line intervention to treat this consciousness disorders. The donepezil, this is a central selective acetylcholinesterase inhibitor. In the late post-injury period, may improve the subjective attention and the memory complaints. The evidence, according to studies, varies from class 2 to class 4. Rivastigmine is another molecule which inhibits acetylcholinesterase and the butyrylcholinesterase. The treatment with rivastigmine in the late post-injury period may improve attention and the working memory. This also helps to improve the declarative memory and secondarily improve in attention, processing speed, executive function, and other neuropsychiatric issues. There is a varying amount of evidence from class 2 to 4, from one study to another study, but there is also class 4 evidence shown in one of the studies that subjective improvements in attention, memory, motivation, and fatigue after the rivastigmine. Acetylcholine is an essential intermediate for biosynthetic pathway of phospholipids incorporated into the cell membrane, which in turn increase the cerebral metabolism and also improve the cognition memory. There is a class 1 evidence for that. And severe TBI patient who they're receiving inpatient rehabilitation program, acetylcholine proved to help to improve the cognition, motor, and psychiatric disturbances, and also shortens the length of stay in the hospital. There is a class 1 evidence for that. But the doses are 1 to 2 grams per day. There are additional medication consideration if patient comes to you, like patients who they have been anti-epileptics, like phenytoin and carbamazepine. They are supposed to produce the cognitive impairments, whereas the valproate appears to be cognitively neutral during this period, may be preferable with either continued prophylaxis or treatment with the post-traumatic seizure whenever it is required. There is class 1 evidence for the valproate. Other component is the education. Education and counseling is very important in the early phase of the post-TBI. And I'll just take, one by one, the attention for the education point of view, the attention, the people who have experienced TBI might have trouble in paying attention or staying focused. So then this can be achieved easily if distraction can be avoided. Focus is done on one task at a time. Breakage of the larger or complex tasks into smaller tasks. The other is the processing of the information. Understand and process the information is slowed down, that can become more challenging, which can easily be dealt with the education, like decrease distraction, allow more time to think about the information before moving on to the next information. Take notes and summarize the information, their own words. Then other difficulties is to expression. So this can be, the communication can be improved with the practicing, communicating one to another to small groups, and someone speaks too fast, then ask them to speak slowly. So likewise, the understanding can be developed. So subsequently, the communication can be improved in the post-TBI cognitive deficient people. Then another area where the education required is the learning and the remembering. This could be done with the help of the structure, the day and routine daily tasks and the activity. One need to be organized for that, and there is a use of the memory aids, such notebooks, and keep track of the important information or keep the reminders, minimize the distraction, devote time and attention to reviewing and practicing new information to memorize would help to get back to these deficit areas to return back. The other area where the education required is planning in the organization. There's a difficulty in planning the day and the schedule appointments, which can be done either to use a calendar to schedule appointments and tasks, list the goals or things that need to be done or when. So easily this can be achieved with this much of the education program to be given. The other is the judgment, reasoning, and problem solving problems, which could only be done with the help of the trusted family member and friends when solving problems. So because they cannot solve the alone, so you require some help. So only trusted people in the family, as if either family member or friends, could help them out to solve these kind of problems. So these are the list of the memory aids which can be utilized for the cognitive disorders. And in this slide, there is a cognitive dysfunction had shown that perception is the one area, then the executive of the functions is another area, visual spatial problem is another area, deficit of memory is the area which could need to be dealt with. So executive function is a purposeful behavior which is necessary to do the all activity of daily living, and it also helpful to do or direct the other cognitive function, and second most common deficit after traumatic brain injury. So executive function is the coordination of multiple cognitive functions to produce coherent goal-directed result. So in that direction, it is very important to treat such entity. And the executive function areas of brain, dorsolateral prefrontal cortex, orbitofrontal cortex, anterior cingulate cortex, which helps to inform information processing or maintenance of the attention, but to keep the working memory, integrating cognitive functions and the problem solving and the response inhibition whenever is required. So these are the common patient symptoms: decrease in intellectual functioning, slowed processing speed, memory loss, forgetfulness, difficulty in language, emotional changes, attention, and difficulty with planning and doing the multitasking work one go. So retraining or restoring cognitive process is the mainstay that have been impaired or by injury or illness. The functional improvements are made over many months or several years. So development of new compensatory skill to enhance daily performance is required to rehabilitate such patients. So these are the cognitive skill areas where one needs to work in the executive function, like just to summarize that: memory, information processing, visual processing, and attention subsequently. So these are the rehab strategies which could be dealt with either process training program, strategy training program, functional activities, computer assisted strategies, compensatory strategies, and so on. This is computer assisted cognitive rehab program which can be done with the mild or moderate or severe deficit, cognitive deficit following the TBI. There are memory strategies, so mnemonic devices, vanishing cues, errorless learning, and space retrieval system is used to do the memory therapy. Then visual field therapy for visual restoration in hemispatial neglect cases. Secondary eye movement therapy is also like rapid eye movements for the having the improvement in the hemispatial neglect. So if adequate therapy is being given in this picture, you can see over a period of time there is how much improvement with the intervention of hemispatial neglect therapy. Then what are the evidences for the cognitive rehabilitation program, cognitive rehabilitation? So there was a review of literature which showed that there is a substantial evidence to support intervention for attention, memory, social and communication skill, executive function, and for comprehensive holistic neuropsychological rehabilitation after TBI. This is a well-supported program after the review of literature which says concluded this. The another study published in the American Journal of Translational Research, which also concluded that non-invasive therapy like repeated transmagnetic stimulation can improve the rehabilitation effect on cognitive impairments in patients after TBI, and it is recommended for the clinical use. It's a non-invasive therapy. So other recommendation for implementation of virtual reality in acquired brain injury rehabilitation. So far, there is a limited research on the use of immersible virtual reality for TBI rehabilitation, but fewer studies they have said that immersive virtual rehabilitation therapy is very important for the TBI rehabilitation when the cognitive functions are affected. Another evidence-based study on cognitive rehabilitation task force of American Congress Rehabilitation Medicine Brain Injury Interdisciplinary Special Interest Group. They have concluded that most of their conclusion based on moderate to limited evidence, but however, they found strong evidence supporting the use of external memory aids to compensate for functional memory problems without necessarily improving the underlying memory abilities. Sometimes it doesn't improve the underlying memory abilities, but they compensate for the memory which is being affected in such patients. The other evidence for direct attention training, the author has been recommended to use direct attention training in conjunction with metacognitive training for the post-acute or mildly impaired clients with the intact vigilance. So that's also helpful in the cognitive dysfunction where there is a mild impairment. There are external memory aids, which include written memory notebook or daily plans could be created and the electronic device can be used. So in this study, they said like the treatment to establish the use of external aids for memory compensation might be considered as a practice guideline to improve the day-to-day life functioning of the people with brain injury. Another study is the effectiveness of cognitive rehabilitation following acquired brain injury meta-analysis, which concluded that, that there is sufficient evidence for the effectiveness of attention training after traumatic brain injury, language treatment for aphasia, and visuospatial treatment for the neglect syndromes after the stroke. Then the remediation for attention, what to be done, what are the evidence, and what are the recommendations. The remediation of attention deficit in the post-acute rehabilitation phase, direct attention training or metacognitive training can be suggested, whereas the computer-based intervention considered as an adjunct to the clinician-guided treatment, and these repeated exposure and practice on computer-based tasks without some involvement and intervention by therapist is not recommended. So it has to be done under the care where the therapist is also involved into the cognitive attention therapy. Then visuospatial rehabilitation, where the visual scanning training is recommended for left visual neglect, and use of isolated microcomputer exercise to treat left neglect after injury does not appear effective and it's not recommended. However, computer-based intervention intended to produce extension of damaged visual field may be considered for people with traumatic brain injury. Specific gestural or strategy training is recommended for apraxia during the acute rehabilitation from left hemisphere injury. The other issues, the communication deficits, linguistic therapies are recommended during the acute phase. Specific intervention for functional communication deficit include pragmatic conversational skills. Specific language treatments such as reading comprehension and language formulation are recommended after left hemisphere stroke patients with the cognitive intervention, and group-based intervention may be considered for the remediation of social communication deficit in such patients. The other communication deficit could be compensated with the social skill training, which involves the pragmatic communication behaviors like listening, starting, and conversation, the social perception of emotion and the social interference, and the psychotherapy for the emotional adjustment. And they can also be trained to do the group social activities like cooking, board games, etc., to have the better communication skill in such subset of patients. Then communication skill can also be achieved where there is a social and emotional perception defect with errorless learning techniques and self-instructional training strategies, which showed modest improvement in judging, facial expression, drawing space, social inferences with some advantage of self-instructional training programs. The memory deficit, the use of internalized strategies such as visual imagery and the external memory compensation like notebooks, diaries, what to do the list, electronic organization pager can also help to improve the memory deficit in such patients. Then comes the semantic encoding strategy. This participants were scanned as they learned list of semantically related, unrelated work. So that can be decided in two groups, related, unrelated, and each list repeated twice. And there are 96 words, out of which 48 are related, 40 is unrelated, were presented over the 4 functional runs. So this is set program of this 96 words. This can be run through to improve the semantically related memory. The errorless learning techniques, which consist 20 sessions of memory skills, which includes the instruction sequence of learning to be used in the patient suffering from severe memory and the executive deficit. It is helpful in teaching new knowledge, and it appears to be effective in teaching specific information procedures to patients with mild executive disturbances as well as memory impairments. These are compensatory strategy training programs to process the oriented memory training, which helps to increase knowledge of memory strategies by using the memory aids, reduce behavior indicative of memory impairment, and also improve performance and neuropsychological assessment of the memory following the intervention of compensatory strategy mechanism. Then externally directed assisted device like pager system can also be used, and these are having the immediate benefits for compensating memory and where the planning deficit is there. Then metacognitive therapy, which is self-monitored or self-regulated therapy recommended for deficit in the executive functioning, which include impairment of the emotional self-regulation, would be helped out by this metacognitive strategy therapy. Then group intervention can also help to improve the metacognitive memory. The strategies are awareness training program, verbal self-regulation strategies, and autobiographical memory cueing to be used as a metacognitive strategies to improve the memory. So we can summarize about the cognitive rehabilitation. It includes this integrated treatment of individualized cognitive and interpersonal therapies following the TBI, which includes cognitive rehabilitation, protocol specific therapy need to be individualized as per the need of the person, of a TBI affected person, then physical therapy, occupational therapy, and speech therapy, which can be either instituted in individual manner or as a group therapy. And the metacognitive and emotional regulation for cognitive deficit, emotional difficulties, interpersonal behavior and functional skills, the mainstay of the treatment, which can improve the community integration, functional independence and productivity, even for patients who are many years post-surgery period. So take-home message is cognitive rehabilitation notes have proliferated in last over 30 years, have been implemented widely in the treatment of cognitive deficit results. These interventions help in cognitive functioning, improvement in the cognitive function and also in terms of improved psychosocial functioning and the vocational outcomes. In order to render these interventions, they must be embedded in appropriate context, be delivered systematically, creatively, and individualized to fit the unique cognitive and psychotherapeutic needs of each individual. However, further research is needed, and cognitive rehabilitation intervention are promising treatment that can contribute to the well-being and quality of life of an individual with TBI. Thank you.
Thank you, sir, for your wonderful speech. Now I request Professor Anupam Gupta, sir, to felicitate Dr. S.L. Yadav, sir, with a gift hamper and his certificate. Our next speaker will be Professor Dr. Anil Kumar Gupta. Thank you, sir. CV दीजिए, CV वाला ये करिए. Next. To the cameraman, in our last presentation, the camera was always focused on the speaker, so try to focus on the slides during the speech itself, okay? So there is a complaint, lots of complaint regarding that. And if there is any question, I would ask the audience to keep it reserved for the last part of the session because we are already late by about 10 to 15 minutes. Coming to Professor Dr. Anil Kumar Gupta, he is an MD from AIIMS Delhi. He is also a DNB and also CEPC as well as MNAMS fellow. His innovation and interest areas include neurorehabilitation, soft tissue surgery, Botox, EMG NCV, robotics and gait lab. He heads the department of PMR KGMC Lucknow, and his topic will be regarding spasticity management, update on spasticity management after brain injury. Over to Professor Dr. Anil Kumar Gupta, sir.
Thank you, Dr. Jagdeep, for nice introduction. Respected Director, sir, my mentor, Professor Yadav, sir, dignitaries, other faculties, resident. So, this one. This. Yeah. I will be able to see it. Okay. So today I will speak on update on spasticity management after traumatic brain injury, which is very crucial part for maintaining the locomotion after the injury. So as we know, spasticity is a common complication of cerebrovascular disease, spinal cord injury, head trauma, cerebral palsy, and progressive neurological disease like multiple sclerosis. And the degree of spasticity may vary from muscle stiffness and slow movement to severe uncontrollable spasm with contracture and fixed joint position that makes any movement possible. So by definition, spasticity is defined as motor disorder characterized by a velocity dependent increase in tonic stretch reflex with exaggerated tendon jerks resulting from hyperexcitability of stretch reflex as one of the component of upper motor neuron syndrome. So globally, traumatic brain injury has an incidence of 1.5 to 2 million per year, among which 75,000 to 1 lakh patients are having severe form of trauma. The heterogeneous distribution of contusions, tissue tears, hemorrhagic damage, and ischemic injury varies greatly, making each patient injury unique. As we compare to stroke, we know that which artery is blocked or where hemorrhage is there, we can delineate the neurological loss. But in brain injury, it is very difficult, and the neurological deficits are varied from psychological disturbances to spasticity, hearing loss, visual perceptions, and so on. Therefore, predicting the spread or even presence or spasticity after traumatic brain injury is very much difficult. The following TBI, the onset of spasticity and associated orthopedic sequelae is rapid, beginning as early as 1 week following the injury. The following areas, in addition to corticospinal tract injury, leads to spasticity in traumatic brain injury, like associated injury to supplementary motor area, premotor area. And more spasticity is more common if there is bilateral motor cortex injury, cortico-reticular fiber tract injury, frontal cortex and anterior limb of the internal capsule, and vestibular and reticulospinal tract. The TBI associated cognitive behavior and memory impairment can make evaluating the and managing spasticity more difficult compared to other causes of spasticity, because you have to give certain exercises, certain movements. If cognition is not good, so your main role is only drug therapies. The evaluation of the patient spasticity usually start relatively soon after cerebral injury. In general, time can vary depending upon the underlying neurological insult, and many cases resolve following the stepwise process, likely due to plasticity. Brain recovers from trauma. Initially, spasticity appear whenever brain takes over. Eventually, in most of the cases, spasticity disappears. If plasticity does not aid in the recovery of motor function, then spasticity will persist. Then we have to tackle that spasticity. Recovery after TBI follow a reasonable predictable sequential pattern outlined by Brainstorm, which is well defined in stroke cases. Although each step follows the other, the process may be interrupted at any point, and this halt all an ongoing process. So evaluation of the patient, a mild increase in tone may not require any treatment and may in fact be beneficial to the patient. Severe, long-standing, unchecked spasticity can lead to deformities of the limb and spine, decubitus ulcer, and severe pain. So we can quantify the spasticity by modified Ashworth scale, which is 5 level score: 0, 1, 1 plus, 2, and 3, and 4. So remember, spasticity is not always detrimental. It is beneficial also. It may help some patient to ambulate, stand, or transfer. Grade 1 spasticity may assist in maintaining muscle bulk, preventing deep vein thrombosis, preventing osteoporosis, decrease pressure ulcer formation over bony prominence, and it can be used as a diagnostic tool. Spasticity can be sign of exposure to a noxious stimuli, infection, bowel impactation, urinary retention, etc. Patient was stable on some antispastic medication. You went to the ward and there was sudden increase of spasticity. So you have to search for this kind of problems. On the other hand, spasticity affect quality of life, like excessive spasticity interfere with function, can cause extreme discomfort, pain in joints with intact sensation, disfigurement, interferes with nursing care, contracture, bone fracture, decubitus ulcer, interferes with perineal hygiene. In patient with fracture, malunion may occur, joint subluxation, dislocation, and increased risk of heterotopic ossification. So how we'll manage the spasticity? Identify the spastic patient, select the functional goal. What we are going to get? Identify treatment options, document and videotape results. The goal of spasticity treatment is improve the function, improve independence level, improve quality of life, and decrease cost of ongoing care. So previously goals were smart. Now everybody is becoming smarter. So goals are also smarter. Smarter means as for a specific, measurable, agreed upon by patient and physician, realistic. That goal should be realistic, time bound. It should be evaluated at a given interval whether this specific therapy is working or not, and treatment protocol should be revised at defined interval program. So therapeutic objectives are reduce excessive muscle tone in affected limbs, increase patient functional capacity, and reduce comfort. And initial management should focus on elevation of external cause of spasticity. Suppose patient positioning is not good, that cause muscle length to shorten. So this increase the noxious stimuli and increase firing of alpha motor neuron to leads increase spasticity, and followed by specific treatment. The prevention is daily stretching, range of motion program, patient education about positioning, avoidance of noxious stimuli like infection, UTI, pain, DVT, heterotopic ossification, pressure ulcer formation, and urinary retention. Posture and positioning in wheelchair as well as bed rest. Patient require frequent repositioning in the bed. The physical modalities and therapeutic, in which stretching, cryotherapy, proper sprinting, I will discuss one by one, inhibitive casting, functional electrical stimulation, and biofeedback. The stretching relief muscle and joint stiffness, and it carries over effect due to mechanical changes in musculotendinous unit or plastic change in central nervous system. Twice a day or more is recommended, at least 50 movement twice a day. Emphasis for muscle at risk. Every muscle need not to be stressed. The muscle who has spasticity or shorten, they need to be stretching stressed. Heating or warming before stretching to reduce pain, promote musculotendinous lengthening, and reduce spasm. So two types of depending upon the expertise of occupational therapist, one can use Bobart technique and proprioceptive neuromuscular facilitation. Another is use of cryotherapy, which decrease muscle stretch reflex excitability, reduce clonus, and increase range of motion. Mechanism is decrease sensitivity in cutaneous receptor, which slowing the of nerve conduction, which affect the ascending part of spasticity pathophysiology. Another one is casting and splinting, that increase range of motion and decrease reflex tone. Prolonged stretch exert an inhibitory effect on motor neuron excitability, elongation of musculotendinous unit, and increase in number of sarcomeres. Biofeedback is another way to reduce the spasticity in non-pharmacological method, that you have to train the patient to relax the spastic extremity, and it is reported to be useful in dorsiflexion of ankle. Another one is electrical stimulation. Cyclical use of electrical stimulation decrease upper extremity contracture, improve motor activity in agonistic muscles, reduce tone in antagonistic muscles, and in lower limb, stimulation of psoral nerve, decrease extensor tone and increase strength of ankle dorsiflexion has been observed. Peroneal nerve stimulation is used to suppress ankle clonus. In spinal cord stimulation, dorsal cord stimulation is another interventional procedure for spasticity management. The main stem of therapy is pharmacological. The prototype drug is used is baclofen, which is analog of GABA. It causes presynaptic inhibition of activation of GABA B receptor and inhibits both mono and polysynaptic reflexes. There are few side effects like sedation, weakness. Most important is sudden withdrawal of drug can cause seizure and hallucination. In traumatic brain injury, where seizures are there, this drug should be avoided. Another drugs are there because it causes lowering the threshold of seizure, and it is usually started at 5 mg BID or TID dose, but you can give up to 120 or to 40 mg per day. The another drug is diazepam, but it is usually unsuitable in patient with traumatic brain injury because of the deleterious effect on attention and memory, which is almost there in every severe traumatic brain injury patient. So another drug is dantrolene sodium. Unfortunately, it is not available in India. It directly acts on striated muscles, blocking calcium release from the sarcoplasmic reticulum, and it is preferred drug in spasticity of cerebral origin like stroke, cerebral palsy, and head injury. It is hepatotoxic in 1% cases, so periodically liver function test is mandatory, and those are 25 mg to 400 mg per day. So another good drug is tizanidine, which is centrally acting alpha-2 adrenergic agonist. It facilitates glycine and inhibit release of glutamate and aspartate. It is useful in spasticity in MS and stroke. Also, clonidine is also analog of tizanidine, which can also be used in case of traumatic brain injury, but most of the studies are from spasticity of spinal cord injury. So tizanidine is also a hepatotoxic drug, so periodic LFT should be done, and it is started at 4 mg day up to 36 mg per day can be given. Dose has to be reduced in renal impairment cases. I have to speak about clonidine. The other oral agent, gabapentin, chlorpromazine, phenytoin, rigampicin, all four drugs we use for different purpose in traumatic brain injury. They also have some action on spasticity. There are new other drugs which are on research module, not so much recommended for the spasticity, but they tend to reduce spasticity. The another part is chemical neurolysis nerve block or motor point block, in which we use chemical agents to nerve to impair function. They improve range of motion, lessening of clonus, increase in speed and dexterity. For differential block, we use lidocaine or bupivacaine. Whatever nerve we want to block and want to see the effect, we use lidocaine and bupivacaine that interferes with permeability in sodium ion, but effects are short-lived. Because of this property, we use this drug before permanent neurolysis. So commonly we use phenol, which is 2 to 7%, and we usually use 6% aqueous phenol, which produce axonal destruction for this. And another option is ethyl alcohol, but in ethyl alcohol there is painful neuropathy for at least 24 hours. In phenol injection, there is no pain after the injection. So we can use different nerve blocks for different kind of deformity, like musculotendinous nerve block for hemiplegic elbow flexion deformity, C5 quadriplegic, median nerve block, obturator nerve block for scissoring gait, paravertebral block of upper spinal nerve for flexor spasticity, tibial nerve block for varus ankle or clang of toe. The complications are dysesthesia. In mixed nerve, there is chance of sensory impairment, local pain, muscle weakness, transient swelling, and rarely convulsions. Another drug is botulinum toxin, which is very much highlighted and marketed like anything. Botulinum toxin inhibit release of acetylcholine at neuromuscular junction, causing reversible denervation atrophy. Clinical effect limited by collateral sprouting. It is effective up to 4 to 6 months actually. The contraindications are sensitivity to botulinum, patient is on aminoglycoside or spectramycin, any previous neuromuscular disease, pregnancy and lactation. Can be given with or without EMG guidance. Usual dose is 25 to 200 unit per muscle. Maximum dose is 400 unit per session. And session should be at least 3 months apart to prevent antibody formation. And onset of action occurs after 24 to 72 hours, which last about 2 to 6 months. So side effects are minimal, but in upper limb injection dysphagia from cervical injections are noted. Antibody formation is another side effect which can lead to resistant to frequent repetition of Botox injection. Another thing is intrathecal baclofen pump. Direct, in that direct delivery of baclofen into the CSF, indications are generalized spasticity with intolerance or lack of response to conservative treatment, and preserve function below the level of function. Main use are in spinal cord injury and multiple sclerosis, cerebral palsy, and traumatic brain injury. So there are two component pump and reservoir, and catheter is implanted into the subarachnoid space up to L1 or D10, and the pump is filled by telemetry by transcutaneous injection. The side effects are drowsiness, headache, dizziness, nausea, hypotension, weakness, and problem associated with pump itself, and in overdose respiratory depression can occur. Another thing for this pump is that expertise is not available in every major city, so it is very problematic to refill the reservoir, and if any problems occurs like kinking, so there is suddenly hypotension and convulsions, and emergency people are not trained everywhere to tackle this kind of problem. So spinal blocks nowadays done very rarely. Previously, when latest things were not there, spinal blocks were used to reduce excessive muscle tone. Then surgical procedure like orthopedic procedure for spasticity in adult patient and child where conservative measures have failed, like shoulder, if already contracture is there or spasticity is more than, we can release spastic muscle like in shoulder adducted, internally rotated. We can release pectoralis major, subscapularis tendon release. Painful shoulder subluxation, we can create biceps tendon sling. For elbow flexor spasticity, step cut lengthening of bicep, fractional musculotendinous lengthening of brachialis muscles. For extensor spasticity, we lengthening of triceps. For wrist and we can differently lengthening the short contractive muscles. For lower extremity functional deformities, for limb seizing, we can either go for obturator nerve block or we can do obturator neurectomy also. For crossed gait iliopsoas recession, hamstring lengthening. For stiffening gait, selective quadriceps release, equinovarus foot TL lengthening, splat procedure. For spastic valgus foot release and transfer of peroneus longus muscles. For static deformity, we can release the contracture around hip adductor contracture. We can release adductor longus and gracilis release. It is very short surgery. Hip flexion contracture release of sartorius, rectus femoris, anterior fascial lata, iliopsoas pectineus. For hip extension, proximal hamstring release. Knee flexion contracture, we can go for distal hamstring release and so on. There are certain neurosurgical procedures which are well defined in case of cerebral palsy. There is no data about traumatic brain injury patient itself. To sake of completion the topic, I have included this. Selective dorsal rhizotomy, in which sectioning of selected dorsal segment roots to modulate afferent sensory inputs. It is good for young spastic CP patient with good motor control who have some locomotion. Side effects are weakness, sensory changes, bladder dysfunction, bladder will be incontinent, and hip subluxation. Another one is radio frequency rhizotomy and dorsal root entry zone tomy. And neurosurgical procedure, cordotomy, codectomy, mylectomy. To summarize, vigilance is needed to look for and treatment to treat concomitant injuries such as fracture, infection, and pain in these increased muscle tone. Acute phase, the basic principle is mobilization as far as the cerebral injury allow, and drugs should be used with caution in the recovering brain. Botulinum toxin play a key role in managing focal spasticity, and surgical options should be considered in the long-term management of refractory spasticity. Thank you.
Thank you, Professor Anil Kumar Gupta, sir. He is heading KGMC Lucknow, and that is one of the institutes that deals with spasticity in its full spectrum. We had always known that Safdarjung, my alma mater, AIPMR Mumbai, Patna Medical College, these are the institutes where PMR department handles the spasticity from its medical management, exercise management, blocks, surgery. Every spectrum is being managed by these 4 institutes. We have known this thing since beginning, but later on few other institutes are also coming up. Sir heads one of them. So now Dr. Satyaki Ganguly sir to felicitate our speaker Anil Kumar Gupta sir with a memento, certificate and the gift hamper. Thank you, sir. Yeah. CV slides. Our next speaker will be Professor Dr. Anupam Gupta. He will be delivering a lecture on disorders of consciousness, rehabilitation strategies and outcomes in brain injury. Anupam Gupta sir heads the NIMHANS Neurorehabilitation Department. He is an MD PMR and he is also an ICMR International Fellow, Senior Scientist Category 2017-2018 UK, and he is also running the postdoctoral fellowship program, which is probably the single such program in India on neurological rehabilitation for the last 10 years for post-MD PMR residents. And sirs, most of the students are well settled in corporate and government setup. They are all renowned. Sir is basically a teacher of teachers, and he's also the deputy chief editor of Indian Journal of PMR. He is member of editorial board of Journal of Neurosciences in Rural Practice. He is reviewer of more than 8 national and international peer-reviewed journals. He has more than 80 publications in PubMed Index journals. They are very much cited. We all know that. And so over to Professor Dr. Anupam Gupta, sir, to talk about disorders of consciousness. Thank you, sir.
Thank you, Dr. Jaideep, for that kind introduction. At the outset, let me thank Dr. Jaideep Nandi for inviting me for this talk and organizing this wonderful, wonderful CME. How to change this from here? Yeah, this one. Yeah, so my topic is disorders of consciousness, rehabilitation strategies and outcomes. So the outline of my presentation would be, we'll start with the spectrum of disorders of consciousness, its epidemiology and etiopathology, the criteria for diagnosis. We basically in rehab people would be using the clinical assessment and outcome measures. And then there are imaging and electrophysiological methods also for assessment of DOC, rehabilitation strategies and rehabilitation outcomes. So if you look at the consciousness, it is a state of awareness of the self and the environment. So for it requires both wakefulness, that is arousal, as well as awareness. So you should be aroused as well as aware about the content, that is sensory, cognitive and affective experience. So arousal is mediated by reticular activating system and its connections in the brain. So if the patient has reticular activating system injury, the patient is likely to be going into the coma. Whereas if the patient awareness, which is mediated by the functional thalamus, cerebral cortex and their white matter connections. So any critical damage anywhere in the pathway, thalamus, cerebral cortex or their connections is going to cause patient who is arousable, but is not aware. This, okay. If you look at the epidemiology, and as I think Director Sir pointed out, we don't have epidemiology in Indian context, but if you look at the Western literature, the incidence of vegetative state in US is 4,200 persons per annum, and its prevalence of vegetative state is 5,000 to 42,000 patients, or 56 to 140 per million persons. And the prevalence of minimal conscious state in US is 112,000 to 280,000. And importantly, more than 40% of the patients with DOC or disorders of consciousness are misdiagnosed as reported by the US and European studies. And unfortunately, we do not have any extensive epidemiological study on DOC in our country. What happens once the patient has acquired a cerebral trauma, whether it is traumatic injury or infection or inflammation or whatever happens, patient becomes comatose, then there are 4 likely outcomes. There could be brain death or chronic coma, which is very rare, or patient may recover or go to the vegetative state. So vegetative state, what is the permanent vegetative state? If the patient remains in that stage for more than 3 months in the cases of non-traumatic etiology, or in the traumatic etiology, if patient is in for more than 1 year, we call it as a persistent or permanent vegetative state, and the likely outcome would be death. And if the patient is showing recovery, going to the next stage from vegetative state, patient will go into the minimal conscious state. And I will not be describing all these things. I hope most of the guys who are handling brain injury know these stages. Then there would be post-traumatic confusional state, and then patient would progressively show improvement in independence, which would be variable depending upon a number of factors. Or the 4th likely outcome would be locked-in syndrome. We know where the patient is having pontine injury or pontine lesion, or patient is having peripheral lesions like ALS, motor neuron disease, tetraplegia, where the patient has the awareness, has the arousal, but not able to move his limbs, right? So again, just to illustrate it, in a normal person, normal consciousness, we have maximum arousal, maximum awareness. Whereas comatose stage, sleep and anesthesia, we have minimum arousal and minimum awareness. In vegetative state, patient has maximum arousal, but the awareness is almost not there. Whereas in minimal conscious state, patient has maximum arousal, but awareness would vary depending upon a number of factors. And in the locked-in syndrome, as I told in the previous slide, patient has maximum arousal and awareness. So what is the etiology? The most common cause which we would come across in our day-to-day practice would be probably cardiac arrest causing hypoxic ischemic encephalopathy, and the patient is coming to us in the comatose stage, traumatic brain injury, or patient is having either hemorrhagic stroke or ischemic stroke. These are the most common causes we come across. But there are other causes also of DOC, which could be infections and inflammatory structural causes like trauma, like neoplasms, hydrocephalus, metabolic causes like hypoglycemia, nutritional, or there could be toxic causes, hypertensive encephalopathies, burn encephalopathies. So these are the other common causes of or known causes of disorders of consciousness. So this is another way to illustrate level of consciousness starting from coma, going up to the post-confusional state, and then showing more and more independence in activities of daily living or in the cognitive domain, motor domain, sensory domain, psychiatric and behavioral domain, like that. So assessment, how to do the assessment? Probably in rehab, we are more rely on the clinical examination and outcome measures because we want to quantify it just to show the effect of rehabilitation. So you have to do the clinical assessment, look for the outcome measures, electrophysiological assessment, which is probably more of the domain of neurology. Some neurosurgeons, neurocritical care persons would be doing like EEG or evoked potential, imaging studies like doing fMRIs or metabolic scans like PET scan, another way of doing the assessment. So this is a very interesting, busy slide, but just depicts what happens in various stages. Like we know brain death, my patient will not have any awareness, wakefulness, brain death would be there. Comatose patient, again, awareness and wakefulness will not be there. But brainstem response would be depressed, motor reflexes would be, there will be posturing, decorticate or decerebrate posturing would be there. EEG would be showing polymorphic data, evoked potential would be variable, cortical ERPs would be absent. And if you look at the fMRI, the brain will be resting fMRI showing less than 50% of the brain working in the patient. Again, same in the vegetative state, awareness will be absent, wakefulness will be present. And as you can see in the table, other things, what is happening. Minimal conscious state is important for us because as all kind of setup in NIMHAN setup, we take the patients only when they are in the minimal conscious stage, at least they have one step comprehension is present so that we can build upon that program. If the patient is simply vegetative comatose, we usually don't prefer taking such patients because you don't know what's going to happen. Patient would be simply lying there. You have to give preventive rehabilitation, not active rehabilitation. So minimal conscious state, my patient would be having awareness, would be having wakefulness, brainstem reflexes will be present, motor reflexes would be variable, EEG would be non-specific slowing, and evoked potential would be preserved, and PET fMRI would be showing reduced activity, and prognosis would be variable depending upon a number of factors. And in locked-in syndrome, as I told, everything you would find is intact. Then coming to the rehabilitation, what to do with these patients? As I told you, in our setup, we don't prefer admitting the patients of comatose or vegetative state. We prefer at least single step comprehension is there in the patient so that we can build upon the program, focus the cognitive, psychiatric, motor, sensory, and other domains. So a comprehensive team would be requiring a clinician. In our setup, of course, rehab physician would be taking care or leading the team. You would require physiotherapists, occupational therapists, orthotists, speech pathologists, psychologists. So all these would be important components of a comprehensive rehabilitation team. What will be the issues you would address, like consciousness, awareness, cognition, behavior, sensory motor, activities of daily living, secondary complications occurring as a result of primary insult, gait and locomotion, bladder, bowel, quality of life, vocational, and so on. So this is a recommendation from the American Academy of Neurology in 2018, what to do with the patients with disorders of consciousness. And if you look at the recommendation number 1, it suggests the patient should be referred, once the patient is medically stable, should be referred to a multidisciplinary rehabilitation team for further diagnosis, prognosis, and addressing the various issues associated with the disorders of consciousness. And it has got level B evidence also. So these are the outcome measures used in a rehabilitation setup, and different setup, depending upon what kind of patients you are admitting in a rehab setup, you will be using these scales. And of course, we don't use any of these scales. But the most commonly used scales in the literature for patients with DOC is coma recovery scale revised. So if you see the literature, the maximum references you will be finding with coma recovery scale revised. And what are the components of this? It has got auditory function scale, visual function scale, motor function, oromotor or verbal function, communication, arousal. And there is a denominator of 23. The more the patient scores, better are the chances of the patient is showing good recovery out of DOC. Another scale which is used by all is the Glasgow Coma Scale. And of course, we also use Glasgow Outcome Scale also. And our patients are 3 or better, only those patients we admit in our setup. But Glasgow Coma Scale is probably most commonly used by our neurosurgery colleagues, which has got eye opening, motor response, and verbal response components out of 15. Then, is there any role of pharmacotherapy in disorders of consciousness? And we have a number of studies, but I have taken this one slide which depicts what are the commonly used drugs available in the literature, and they have shown the outcome. Again, we will not be talking about the outcomes, but the drugs which are commonly used in patients with disorders of consciousness are either CNS stimulant or CNS depressant. So CNS depressant drugs commonly used are baclofen, lamotrigine and zolpidem and other drugs. And drugs which are having primary stimulant effect like amantadine, which is of course the most commonly used drug in patients with DOC, amphetamine, antidepressants, both SSRIs as well as TCAs, apomorphine, bromocriptine, levodopa agonist drugs, or pramipexole, methylphenidate. All these drugs have been tried in different studies in these patients. Let's take this one study with the rehabilitation. Can we prescribe more medications, more than one, as pharmacotherapy for DOC? So this one study, it took a retrospective chart analysis of 115 patients with severe TBI, 3 possible outcomes: recovery to full consciousness during the rehabilitation itself, or recovery to full consciousness within 1 year of injury, or meaningful neurobehavioral improvement during the rehab. And the stimulants used were amantadine, bromocriptine, levodopa, methylphenidate, and modafinil. So they used all the stimulant drugs. And what were the results? Number of stimulants usually was not significantly associated with the outcomes. So one stimulant or more than one stimulant did not make any difference in this particular study. And in view of cost, in fact, country like ours, where we are conscious of the cost also, we have to think about rationally whether we should start more than one drug for the improvement of the patient. These are the non-pharmacological measures used for DOC. Deep brain stimulation, of course, which is done by the neurosurgeons, transcranial direct current stimulation, which is a non-invasive method, repetitive transcranial magnetic stimulation, vagal nerve stimulation, which has been in vogue for the last 5 to 7 years. Literature is full of vagal nerve stimulation and outcomes in acquired brain injury, especially in stroke patients, and sensory stimulation. So these are some non-pharmacological measures used. Then what is a core program? Core program is probably traditional, conservative, like we do with all other patients. Similarly, we do for the patients with disorders of consciousness. So coma stimulation program, which is a very basic program, say patient who is comatose or vegetative state, not responding. So giving them stimulation, tactile stimulation, tickling them, patient using specific objects. So this probably is good basic. This is also giving stimulation, efferent stimulation, so that brain registers something, and then probably we'll get response in due course. That's what we are hopeful. The patient will show response in due course. Or in terms of visitors, calling patients friends rather than strangers, relatives visiting the patient, physical contact with the person, as I told, talking about the relatives and friends, familiar names, places, interests and experiences, and showing familiar photographs. Again, whatever stimulation is possible, tactile, visual, hearing stimulation. So this is simple stimulation program for the patient. Or it could be like the patient, our kind of patient who is already has come to us with severe disability and showing signs of recovery, and we have built upon that. We are training the patient. So locomotion or gait, it could be traditional methods like patient is holding the railing and walking in parallel bars using short or long splints or calipers. Or it could be advanced program like body weight support treadmill training, which we have been using in our center for the last 25 years, force platform for balance assessment and as well as training module also. Locomat, which probably Abhishek will be talking about, Kokilovan is using this Locomat. And as you can see, the last photograph, the wearable exoskeletal orthosis, which is prepared by an Indian startup, Bionic Yantra. And we are doing at least 2 projects at present with these patients, locomotion with stroke and spinal cord injury patients, where patient has harness, patient is able to walk, and patient has wearable exoskeleton also. So some of the recent advances. Or again, traditional occupational therapy, where we are focusing starting from the bed mobility of the patient, turning in the bed, making them sitting, quadruped positional, functional ability training, and like kneeling, hand dynamometer to improve their grips, pegboard activity for improving both the gross as well as fine motor hand skills training, shoulder wheel if the patient is developing frozen shoulder or proximal range of motion is compromised, adaptive devices. So these are the components in your occupational therapy section. And if the patient is going further, showing further improvement, then probably focusing on like disabled friendly clothing, modification, toilet modifications, adaptive devices used in the kitchen. So all these adaptive devices can be taught to the patients. Some advances in upper limb rehabilitation, like especially if the patient has clinical presentation of stroke, focal deficits are there, CIMT, mirror therapy, electrical stimulation, MIDO, which we focusing on hand, we do it in our center, or RMEO, which addresses proximal to distal joints in the upper limb range of motion. Orthotic support is important. Again, traditional splints are as good as the new splints. They help in improving the functions of the patient, enhance the mobility, prevent the deformity, correct deformity, or it could be used at best as the resting splint to prevent the deformity. You can see some of the splints like AFOs, AFO, wrist cock-up splint, knee gaiters, and long splints. And for locomotion and transfers, patients can be trained on the wheelchair, which could be manual or could be motorized wheelchair. Patient would be using walkers or walking sticks or auxiliary elbow crutches. These are the basic devices given to the patient for assisting in walking. Botulinum toxin, which we have been doing for the last more than 20 years. Botox for focal spasticity and limb dystonia management in the upper limb and lower limb. A lot of these patients would have bladder related issues. So once the patient, we know patient is confused, not oriented, not alert, then we know we have to put the patient on indwelling catheter or some other strategies. But once we know patient has come out of it showing better improvement, but still has neurogenic bladder dysfunction, of course, urodynamic study would be required. Again, something which we are doing for the last 24 years, doing the urodynamic study and advising the management based on the findings of bladder. Then let's look at some of the studies. Comprehensive systemic review update about the disorders of consciousness, the diagnosis. They have recommended positive EMG response to command, EEG reactivity to sensory stimulation, laser evoked potentials or perturbational complex index, distinguishing between minimal conscious state and vegetative state. Prognosis is better in patients with MCS, as you would understand, as compared to a patient who is in vegetative state. And recovery from prolonged vegetative state, that is more than 4 weeks, is better in traumatic causes as compared to non-traumatic causes. Therapeutic evidence is sparse at best. Amantadine probably hastens the functional recovery in patients secondary to TBI over a 4-week treatment course. So as we all of us know, amantadine is the most commonly used drug in these patients. Tilt-table therapies in patients with DOC. This particular study, the theory is mobilization in standing position. It improves both arousal as well as the awareness. So this study included 50 patients who were in either vegetative or minimal conscious state. Duration of illness was 1 month to 6 months. Randomized into 2 groups, tilt-table alone or tilt-table with integrated stepping device. Intervention was whatever the specific program given to these patients. 1 hour specific treatment for 3 weeks. And coma recovery scale was used as outcome measure. An assessment was done pre, post, and at 3 weeks follow-up. And what did they observe? Recovery was seen in both the groups, whether you are tilt-table alone or with the stepping device. So no additional benefit of giving it with both or giving with tilt-table alone. And spasticity outcomes were same with both the modalities. This is one of our study we published, what, 10 years ago? Yeah. So this study was functional outcome following rehab in chronic traumatic brain injury. And we used disability rating scale, Barthel, FIM, and functional ambulation category as outcome measures in this particular study. And as you can see in this table 3, mean Barthel index score, mean disability rating scores, and functional ambulation. So all the patient shows functional recovery, including locomotion at the end of our study. And out of these patients, you can see a number of them used assisted device also for locomotion, like walker, hemi-walker, elbow crutches, cane, wheelchair. And interestingly, 12 patients out of in our study did not require any assisted devices. They were independent ambulator. Another of our study where we assess the cognitive and functional outcome following inpatient rehab in acquired brain injury. So this study included both traumatic brain injury as well as stroke patients. An outcome measure was Montreal Cognitive Assessment Scale, cognitive FIM, and motor FIM. And as you can see, admission versus discharge, patient shows improvement in all the domains. Motor recovery was there as well as cognitive recovery was there. And at the 3-month follow-up in all these patients, MOCA did not show any improvement, but FIM and cognitive and motor film showed significant improvement. So not only patients improved during the course of rehabilitation, the more tricky question, rehab is sustainable. Yes, at least in this study we showed after at least after 3 months, it was sustainable. In fact, patient shows improvement as compared to discharge scores after 3 months follow-up. Last 2 slides. So this is the 1-year outcome of brain injury patients undergoing neurological rehabilitation. So this was again a longitudinal study. Patients were followed up for up to 1 year. Study had a very good sample size, more than 200, in fact 264 patients. And out of these, the authors observed at 1 year, 27% of the patients succumbed to the injury. They died. 50% or half of the patients had still severe disability after acquired brain injury, whereas 7 to 10% of the patients showed moderate recovery or moderate disability at 1 year. But what were the determinants of good versus poor outcome? Age, that is young age, and coma recovery scale revised discharge level scores, not admission, but discharge level score. Better is the score at the discharge. After 1 year, patient showed better recovery. Or patients who had non-traumatic etiology showed better recovery as compared to those who had traumatic brain injury. Another study, it's a 5-year longitudinal study. Patients were followed up for up to 5 years after disorders of consciousness, and this has a very healthy sample size of more than 300 patients. So what did the authors observe? All patients showed good social participation after head injury, but they were not productive after 5 years. That was the first takeaway message out of this study. They were not productive, but they were doing better socially. Between the two groups, the group which showed better comprehension to the commands did better as compared to the patients who had poor comprehension, who were not able to understand the commands. So better comprehension, patients are likely to do better interaction. Again, they may not be productive at the end of 5 years with severe disorder of consciousness. So just to conclude, disorders of consciousness are heterogeneous group of disorders occurring due to multiple etiopathologies. Periodic and repeated clinical assessment and outcome skills help in assessing the stage of DOC and recovery. Multidisciplinary rehabilitation has important role to play once the patients are medically stable, and it helps in recovery across variable domains. And the goals are better quality of life, improving the ADLs, including locomotion, community integration, vocational rehabilitation, wherever feasible. Thank you.
Thank you, Professor Anupam Gupta sir, for your wonderful lecture. In fact, I am tempted after so many good lectures, I am tempted to keep these lectures and share it with our undergraduate students and PG students, I'm sorry. If the speakers allow us, then we should like to share those speeches because they are so comprehensive. And now Professor Using sir has joined our conference. If sir is present there, I would request sir to unmute his video and say a few words of blessings to the organizations, because he was the first person we have talked with for giving a speech on an important topic of this conference. But he had initially agreed, but due to some other reasons, personal reasons, he couldn't come. So he is personally involved, emotionally involved with this CME, I know. So I would request him to say a few words of blessings for this CME if he is available. Kindly unmute him.
Yes, Dr. Nandi. Can you hear me?
Yes, I can hear you, sir.
Yes.
But I can't see your video.
In fact, I must congratulate you on organizing such a wonderful CME. And right from the beginning, every day messaging and making every speaker comfortable has been your hallmark. And I appreciate this is how the CMEs or any meetings should be organized. We should learn from you. You have made a big gathering. I mean, in a remote institution, a new institution, you have created a big impact, as is evident from the words of the director. And I am very happy that we have such a large audience online as well, including me. And I really miss coming over to you. I would have definitely come and enjoyed everything, but the requirements at Jaipur in our institution were such that I couldn't travel. Thank you so very much for giving me this honor, and look forward to meeting you and being a part of the similar programs in future. Thank you.
Uh, Thank you, Professor Using sir, who has been the head of AIIMS New Delhi PMR department for long and has been a teacher of many of our teachers. Thank you, sir, for joining and giving us all your heartfelt blessings.
Thank you.
Now we are going to the next part of the scientific session. Maybe our director, sir, will be leaving us, but we have to continue our scientific session. And thank you, Director, sir, Professor Nitin M. Nagarkar, for joining us in this CME and giving you this wonderful speech that set the tone for this scientific session regarding the necessity and relevance of brain injury rehabilitation. Our next speaker will be Professor Dr. Abhishek Srivastava, sir, who is the who is the head of the neurological rehabilitation unit of, who is the director? Okay. Before going to the next speaker, we will like to invite Professor S.L. Yadav, sir, to hand over the mementos, certificate and gift hamper to Professor Anupam Gupta, sir. Thank you, sir, for your wonderful talk and agreeing to come here and share your knowledge here. That was a wonderful speech. Thank you, sir. So our next speaker is Professor Dr. Abhishek Srivastava, sir, who is an MBBS, MD, DNB and PhD, and he is also the director for Center for Rehabilitation, Kokilaben Hospital, Mumbai. He is trained in United States, Europe and Singapore. He is the honorary staff of Shepherd Medical Center, Atlanta. He has edited one book, 7 chapters is to his credit. There are 40 publications. He is always giving lectures beyond his busy work schedule. He has given almost 300 invited lectures. He has special interest is on stroke and TBI rehab, robotics, botulinum toxin, hyperbaric oxygen therapy. He is a WHO expert for traumatic brain injury rehabilitation. He is the chair of Special Interest Group of Multiple Sclerosis, World Federation of Neurorehabilitation. He is the founder director of Indian Federation of Neurorehabilitation. He is the convener of Neurorehab subsection of Indian Academy of Neurology, and he is the organizing secretary of World Congress of Neurorehab and Asia Oceania Conference of Neurorehab held recently in the AOCNR 2021. And basically, Indian famous celebrity brain injury patients or spinal cord injury patients go outside the country to get their rehabilitation done. I have seen personally that from outside India, people come to visit him, and there is always a line behind his chamber. So over to Professor Dr. Abhishek Srivastava, sir, to give his lecture on acute neurorehabilitation after brain injury and recent advances in the field. He is the first person who I have talked about regarding this CME, and he has been the guiding person. So over to Dr. Abhishek Srivastava, sir.
Thank you, Jenny, for the kind introduction, and thank you very much for inviting us. I think it's a great initiative of taking the torch forward, and you are doing good work. And I hope that with the new inpatient unit, you can do wonders in AIIMS RAIPUR. Thank you very much. I just share my screen. Dr. Gupta has made my job much easier. So I will just focus on the recent advances in TBI. Many have been covered by Dr. Gupta already. So if you see people like this with bad traumatic brain injury or require decompression surgeries, how do you think they are at 1 year? We'll see in the end of the talk, how can we help these patients to recover better in long term? This talk will cover basic principles of TBI rehab, the definitions, the assessment, the newer interventions, and the evidence. So what happens in traumatic brain injury? It has 2 components. There's an axonal injury and there's local contusions. The axonal injury causes disconnection, which leads to loss of consciousness, and that leads to coma primarily. And there's a gradual recovery from this condition. The focal contusions will cause focal deficits like cognitive, sensory, motor, whichever part is involved, that part will cause specific deficits. And the recovery of overall patient will depend upon the contribution of both these injuries, how much DAI he has and how much contusions he has. Always remember, no 2 patients are same, the same, similar scans, similar age, they can behave differently in long term. So it's difficult to predict the outcome in the beginning. Now, we spoke about these terms, So what does these 5 things mean? When people don't open eyes, it's called as coma. When they start opening eyes, but they don't respond to any external stimulus, it's called a vegetative state. But people in vegetative state also have a regular sleep cycle. They can sometimes move their eyeballs up and down. When they start showing some purposeful response to external stimulus, be it smiling, crying, looking around, gaze pursuits, tracking something, it's called as minimally conscious state. When they start following commands, take your hand up, they take your hand up, it's called as a conscious state. There are 2 big differentiators. One, between vegetative state and minimally conscious state. Patients who become MCS in first 3 months do well in long term, generally. And patients who don't become MCS, especially in TBI at 1 year, remain in state called as persistent vegetative state. So the differentiator is a very important point in the inpatient rehab. If they enter MCS, they will definitely do well. If they enter VS, if they become MCS in 3 months, they will definitely do well in long term. So what are the best predictor of recovery? One is the etiology, the location of the injuries, the extent of the injuries. Second, age. And third, the duration of unconsciousness. Why? Because if you have more external injury, grade 3 to 4, with bad parts being involved with local contusions, you have less chances of recovery. If you have prolonged coma, bad concept of recovery. If you have advanced age, because brain cannot change much during a specific time, these 3 are big contributors for poor prognosis in TBI. But always remember, people who are unconscious at 1 year, 50% can be conscious at 1 year. At 3 months, 1 in 3 can be conscious at 1 year. At 6 months, even 1 in 5 can be conscious at 1 year, especially in traumatic brain injury. So diagnosis of persistent state in TBI is actually 1 year. In stroke, it's 6 months. In hypoxic encephalopathy, it's 3 months. So we don't see those patients for first 3 to, we don't see them for 1 year. We label them PBS at 6 months, which is wrong, especially in TBI. They have the best chances of recovery among all neurological diagnoses per se. These patients will have multiple problems. They will have cognitive issues, they will have behavioral problems, vision, speech, language, swallow, sphincter, sensory, motor, tone, pain, sleep, all can be involved. So our job in rehab is to identify all these deficits in detail and treat them with the help of a multidisciplinary team. Now, how can we change the brain? When we were studying medicine, we were told we can't change the brain. But now there's evidence to show that brain can reorganize. So what are the principles for recovery? This concept is borrowed from stroke literature, but the concept remains same. In the initial period, if someone has a mass effect in the brain, we do a decompressive cranectomies, this midline shift, or we do give mannitol, do the anti-edema to reduce the edema. Why? So we can have more reperfusion of the injured part of the brain. With time, in first few weeks, swelling starts to come down, there's less edema, and brain tends to change itself. This happens automatically. Also, there are medications to reduce focal swelling. There are decompressive surgeries to reduce the edema. What we don't know, we can start some medication now very early, which can help to improve arousal and speech language pathways in brain. What happens in the first few months is very, very, what in rehab we do. Brain recruit additional areas to perform new function. That's called as compensation. Or other part of brain takes over function. That's called as reorganization. This ability of brain to change in response to a stimulus is called as neuroplasticity. So what we are doing in rehab is primarily to somehow harness the neuroplasticity. How can we do it? One is spontaneous in first few weeks to up to 3 months. Second is triggered. We can trigger it by 2 ways. One is intensive training, which is called as experience-dependent plasticity. If you can't use your hand, make a person use his hand. You do it 10 times in a day, 30 minutes, 20, whatever you can, maximum you can. That's called as task-specific training. You can do for speech, for language, for swallow, for movement, upper limb, lower limb. Second are newer agents called as biological treatments, which can be medications, neural stimulation, HBOT, and so on. We'll see in detail each of them in short, one by one. Also, some more facts. There is neurological recovery, there is neurological rehab. Both things go hand in hand. There are 2 types of recovery. One is called as spontaneous recovery. First 3 to 6 months, depending upon the amount of injury a person is having, the edema will settle down, some changes will happen. We can even now modify this by new interventions. Second is functional recovery. You can't reduce the impairment, you can still make a person walk better. That's functional recovery. Primarily, again, based on neuroplasticity and training, primarily based on rehab. Same way, there are two concepts of neurological rehab. One is compensatory rehab. If you can't walk, you give a stick. We all know, it's well recognized. Still needs training and rehab. Second is remediational rehab. Can we restore function by reducing those 9-10 impairments on cognition, speech, language, motor, all those things? We can do that. We'll see how it's being done. So how to assess these patients who are in a vegetative state or MC state in the beginning? We all know about Glasgow Coma Scale, very well recognized. You all know it's eye response, verbal response, and motor response. 4, 5, 6, maximum score is 15. Those who are less than 9, less than 8, do bad. Those who are 8 to 11 is moderate, and then 12 to 15 is mild. Second is Rancher Loss scale, 1 to 8, very important scale, especially to plan rehab in the inpatient setting. It's a descriptive tool. When there's no response, is stage 1. When there's resting, no movement, stage 2. When there is some spontaneous purposeful movement, it's called as 3. When it's confused, amnestic, inattentive, stage 4. When he's not agitated, but still confused, called stage 5. When he is conscious, following command, but lacks problem-solving skills, it's called as stage 6. When he followed daily routine, but needs some supervision, called as stage 7. And when he's completely independent, stage 8, can have some cognitive deficits. So the first 1, 2, 3, 4, especially first 1, 2, 3 have problem, and 4 to 6 need inpatient rehab, aggressive, and 7, 8 can be independent at home in long term. Another scale to primarily identify the MCS and VS, it's Coma Recovery Scale revised form. It has 6 components: auditory function scale, visual function scale, motor function scale, oromotor scale, communication scale, and arousal scale. We should do it every week in our inpatient setting. This is the best scale to differentiate between a vegetative state and a minimum conscious state patient. Then in lockdown, there are 2 scales, one is called Glasgow Outcome Scale, how they are at 6 months or 1 year. 1 is death, 2 is PVS, 3rd is severe disability, no cortical function. They can be without tubes, and they can be conscious but disabled. Stage 4 is moderate disability, which means they are disabled but they're independent. Stage 5 is very good recovery. So people who come in stage 2, they need aggressive care. If they can reach stage 3, they can be managed at home in the low-cost setting. And stage 4 can be independent. Can't go to work, but can live himself in the house. And stage 5 can actually go back to work also. No. The scale is called a disability DRS scale, also called a disability rating scale. This is a TBI specific scale, can be used right from coma to community stage. A good quantitative scale. The first is arousability, is same like your GCS component. Then there's cognitive ability, then dependency, and psychosocial adaptability. You can use this scale right from day 5 to 1 year in patients with TBI. No interventions. Gupta already spoke about most of the interventions. I will just tell you in short about some which are getting more impetus in these days. So if you open textbook of medicine, how to treat patients with acute TBI, not much is available. We all know therapy helps. But beyond therapy, what can we do? We can do these 8, 9 things. Remove obstacles from recovery, treat medical complications, multimodal sensory stimulation, tracheostomy management, very important, pharmacotherapy, HBOT, music therapy, early mobilization, botulinum toxin, tone management, and neural stimulation. We'll see one by one. Before we do these things, we should have a team. A team is very important. We should have a not just neurosurgeon intensivist with us who can help us in case of emergencies, be it massive seizures, be it the required decompression surgeries again, need to be transfer into a ventilator requirement, a rehab physician, a nurse, a physical therapist, an occupational therapist, a speech language pathologist, a psychologist, a social worker, an orthotist, a nutritionist. This is multidisciplinary team, which is patient-centric primarily. What are the interventions we do in that stage? There are 4 basic interventions. First and foremost, being physicians, you take care of the medical problems of the patients. They have tracheostomy, they have Ryle's tube, they have PEG tube, they have indwelling catheters, they have diabetes, they have hypertension, they have autonomic instability, they have spasticity, they have pain. To be able to provide enough medical care yourself, other than emergencies, to run that program. Second, you have to provide training for sensory motor and functional deficit with the help of our therapy team. We should be able to provide assessment and training for cognitive, communicative, and thorough deficits, and target psychological and social issues. That's why the whole team is required. What is prescription? It's a big prescription of pharmacology, botulinum toxin or pain blocks, corrective casting, surgeries, robotic assisted training, HBOT, all type of therapies packaged, at least intensive therapy in first few months. We call this 66 concept. We are able to provide our patient at least 6 hours of therapy a day for 6 days a week for at least 6 weeks. Patient who comes in VS or MCS, they need venous plastic at that time in first few months. Use that time to maximize what you can give back. They undergo physical therapy twice, occupational therapy twice, speech language therapy twice, or psychological therapy every day, depending upon what's feasible. We work 8 to 8 every day, so we can have enough rest in between. Patient comes, spend 2 hours in morning, then they get rest 2-3 hours, 2 hours in the afternoon, again in the evening, so we can bombard the brain with maximum stimulus possible in the first few weeks or months after TBI. Complications. First job as physician is to identify these complications. Multiple things go wrong in first few weeks after TBI. The cardiovascular issues, mainly dysautonomia, catecholamine excess, the respiratory issues. It can be apneic episodes. They can have pulmonary edema, which is neurogenic. They can have low respiratory infections or ARDS. The endocrine problem is very, very common. Pituitary dysfunction with GH deficiency, hypothyroidism, low ACTH. They can have posterior dysfunction causing SIADH or typhus insipidus. You have to keep a watch over their hormones, their sodium levels. They're in hypermetabolic state. They can have peptic or Cushing ulcers. They can have a lot of immunological problems with pro-inflammatory cytokine release. They can have hematological issues. So if we are aware of that, we can pick up these things and we can treat them. The big list of complications we all know, it's common in any inpatient rehab unit. The concept remains same. Hydrocephalus, delirium, encephalopathy, seizures, depression, fever, saturation, endocrine problems, tracheostomy issues, motor weakness, thromboembolism, aspiration, pressure, ulcer, and so on. I'll focus on 2 specific things. One which is very common is called as, we used to call it PAID syndrome earlier, now we call it as PSH, paroxysmal sympathetic hyperactivity syndrome. So if any person has autonomic dysregulation, which means they have tachycardia, tachypnea, unexplained fever, you have to first rule out infection, sepsis, encephalitis, withdrawal syndrome. Many times they are taking alcohol or drugs. If you can remove that, calculate something called as a PSH AIIMS score. If scores are more, it's possible that patient is having PSH syndrome. The patient with tachycardia, tachypnea, hypertension, hypothermia, hyperhidrosis, posturing. Any one of them, mix of them, 2, 3, 4, 5 of them. Always start first simple measures, non-pharmacological. Avoid external stimulus, rehydrate them, correct electrolyte imbalances, reduce environmental stimulation, give them good calorie nutrition, and then you can try HBOT in refractory cases. If it fails, you can start pharmacotherapy. The commonly used drugs are, if patient has more of sympathetic activity, you can give beta blockers. If they have more of posturing, you can use dopamine agonist or muscle relaxants. If they have a mix of both, if they have a mix of hyperthermia along with hypertension, tachycardia, you can even try centrally acting alpha-2 blockers. So commonly used drugs are propranolol, very commonly used. You can use clonidine, centrally acting drug. If they don't respond, you do start primarily opioid agonist at that time. Another thing which is commonly being missed is heterotropic ossification, which is formation of normal bone at abnormal sites, maybe around the joints, in hips, knees, shoulder, elbows. The chances are more people who have bad spasticity, those who have a pre-existing fracture, along with that, a coma more than 2 weeks. A gold standard is triple phase bone scan, not required in most of the cases. You can do a simple X-ray and ALP. You can do a CT maximum you can't pick up in the X-ray. You can start indomethacin or etheric oxide in the acute to reduce the inflammation, and then give etidonate, which is not available in India mostly, in alendronate to reduce calcium levels in the blood. And if it's too much causing problems, do an MRI, see where it is, make sure the bundle, and plan for a surgical excision, followed by one single shot of radiotherapy, 8 gray, which can prevent the recurrence. Then Dr. Gupta spoke about multiple sensory stimulation. We all know about that. The multiple senses we have: auditory, visual, olfactory, gustatory, tactile, vestibular, vibratory. When we are in coma or VS, the whole concept is to send inner signals to the brain. One is to make him stand. Second is to use these 6-7 modalities and stimulate them. There are kits also available. Family can do it. Now, how, when, and how much should we do it? There are some studies now available where people have shown that multimodality stimulation helps in improving people with poor GCS. And there's a good RCT from Mega et al., where they've compared people who got multimodality stimulation 20 minutes 5 times a day versus some people get twice a day 50-minute session. Some get only conventional physical therapy. So they have shown that people who got 20-minute stimulation 5 times a day do better than group B and C. Very low cost intervention, doesn't need anything. You can use a headphone, you can use some things to stimulate the olfactory system, gustatory system, visual system. Teach the family, they can do it. Doesn't cost anything, but it helps significantly in the people who are in coma or vegetative state. Actually, there's a Cochrane review that says that it helps, but they don't know at what frequency to be done. Therefore, this trial came by Mega et al. And it clearly says that do it multiple times in a day in short course, multiple times. It's better than doing it twice in a day. Pharmacotherapy. Your physician want to start medications. Always remember the concept of detrimental drugs. When you go to see a consult in the ICU on day 5, day 6 post TBI, before adding any medication, first see these things. Are these patients on these commonly prescribed drugs by our ICU and neurosurgical colleagues? Most patients actually are on phenytoin or phenobarbital. Phenytoin is gone now. Still, people give phenytoin now. Then came levetiracetam. So always remember, we should avoid giving drugs which affect GABA mechanism or which counters the dopamine or which counters the norepinephrine in the brain. So some people are on haloperidol for agitation, some are on clonidine for long-term management of PSH or prazosin, or some are on clonazepam, very commonly given in significant dosages. There are newer drugs available for agitation, like olanzapine or quetiapine. We should use that in spite of giving haloperidol, and we should give her new antiepileptics instead of giving phenobarbital or benzodiazepine. The first job is this. Then, what medication can we add? There are 3 medications which are commonly used to improve arousal in patients with VS or coma: amantadine, Z-drugs, cefenadine. What is the evidence for that? This is the first trial from a rehab inpatient which has come and published on NEJM for pharmacotherapy actually. It's an amantadine. They give amantadine in a control group in patients who are inpatient rehab, and measure the DRS scale. It's given for about 4 weeks period. You can see here, patients' lower scores are better. Patients with amantadine were better than the placebo group. And if you see here, this is GOS, DRS, moderate disability, severe disability, vegetative state. So patients in amantadine group were 30-40% less in vegetative state. They move more towards extreme disability to moderate disability. This is first 3 months. So it helps people to go out of vegetative state towards extreme disability state, which is good. Now remember, this will not work alone. This will only work if patient getting inpatient therapy aggressively along with that. Risk is seizures, but it's quite safe drug. If people having recurrent seizure, don't start it. Otherwise, it's a safe drug to start. 100 mg OD, go to TDS, and stop it by about next 3 months. Second drugs are called as Z drugs, very commonly used. All of your patient relative will want to ask this question: can we start Zolpidem for our father, mother, or son? Why? Because there are some case reports of miraculous recovery. People who are not sleeping, have an altered sleep cycle, they got zolpidem, they slept well for 2 days and they woke up. People thought they become conscious. But it's a relatively safe drug, can be tried in people with MCA stage actually. There's a larger trial which shows that it doesn't help much. So people who have a lot of sleep issues in MCS, you first try melatonin, regular sleep cycle, doesn't help, you can add zolpidem, can help some people. Third is methylphenidate. It's a good drug to actually improve fatigue or cognitive dysfunction in long term after TBI. In the initial period, it can trigger seizures, and we don't generally use it. Even in the long subgroup analysis of meta-analysis, doesn't help much in the acute stage. It's a good drug in long term people who have attention problems, cognitive issues in TBI. Now, HBOT, it's a new thing. It is hyperbaric oxygen therapy, can be delivered in a monoplace or a multiplace chamber. This is a monoplace chamber. One patient is in the machine. You can increase the atmospheric pressure from 1 to 2 up to 3 atmospheric pressure. So what it does, we have oxygen in the hemoglobin and in the dissolved plasma. Your HB is fixed, whatever you're having. But if you can breathe oxygen at high pressure, you can have more dissolved oxygen in plasma, which can go to the injured part of the body and can help in healing. So if you give oxygen about 2.5 ATA, you can go up 20-fold increase in the level of dissolved oxygen content in the blood. This helps. This helps by multiple mechanisms, reduce inflammation, inhibit apoptosis, reduce ICP, promote some angiogenesis. This significantly helps, especially in acute to subacute TBI. So Cochrane review says that a pooled data of all these studies of 7 studies to 571 patients, they have shown that if you start HBOT in acute subacute stage, you can prevent 1 death in 7 patients. People say it's nothing big, but NNT7, 1 in 7 is not a bad thing. But is preventing death enough? We don't know in rehab as such. Also, they've shown that GCS points improve by 2.68. Now, if 5 becomes 8, people say it's not meaningful. But if 8 becomes 11, it's meaningful. If 9 becomes 12, it's meaningful. So it's a good drug to add in people who have GCS less than 9, who have severe brain injury and are in inpatient rehab in the subacute stage. What evidence is coming now? In moderate to severe TBI, alteration level of consciousness, HBOT with standard care, the weak recommendation in favor now. GO outcome scale mortality, weak recommendation in favor. So evidence is coming up now. I hope in the next 5 years we'll get enough facilities to show this helps. One of our simple studies of patients with HBOT who were having disordered consciousness with less than 9 GCS, 51 patients, 8 women, 43 men, of which 43 underwent decompression surgeries, 40 plus minus years age. The HBOT about 44 days mean after the injury, and 20 session HBOT was given. These are severely injured patients with GCS 9 who were on ventilation. The day they were out of ventilation, out of the ICU, we started HBOT about 40 hours of out of ventilation stage. You can see here Glasgow Coma scale, significant change in Glasgow outcome scale, significant change, even coma recovery scale, significant change. The summarize is like this: about 56% of patients were out of vegetative state when they got inpatient rehab along with HBOT. The randomized study is a prospective study, but if we compare data of the last 5 versus previous 5 years, addition of HBOT, we are getting better outcomes in these patients. Tracheostomy management is a big differentiator. Always remember, we don't take patients for inpatient care, they are on tracheostomy. But it's easy to manage and it's easy to remove also if you follow a specific protocol. Always remember, don't remove tracheostomy until patient is safe to swallow. Not food, swallow saliva. So what you can do, you can just give a colored liquid orally. It's called as modified Evans blue dye test. You have blue green colored liquid. And then see they're following it well or not. You can do a suction here in the tracheostomy. If it's not coming in the suction, it means he's able to swallow it. There is no aspiration. Then if you can do that, you can deflate the tracheostomy cuff. So remember, tracheostomy has a cuff, a blue cuff. When air is there causes inflation, you deflate the cuff, which means you're able to, patient able to swallow the dieters. You can deflate the cuff. They're swallowing themselves. You can put a speaking valve. If they are non-aphasic, they can speak also. It's called as passive mute speaking valve. The patient can speak with tracheostomy, they can eat with tracheostomy. Both are possible. If they can do that, go to next level. We all have X-rays in our hospitals where they have fluoroscopies inbuilt in the machine. So you can do a video fluoroscopic swallow study, also called as modified barium swallow study. You will give liquid, semi-solid, and thick liquid food orally, and you will see where it's going. This person has a tracheostomy, we deflated the cuff. Well, they can speak also. Now we're giving some 3 different consistencies of liquid, thick liquids, in a paste consistency. You give it orally. When he's swallowing it, you can shoot in the fluoroscopy. You can see where food goes there. Now, if it goes straight inside, this is your esophagus, this is your laryngeal inlet. If it goes straight here, it's in the esophagus, there is no aspiration. If it comes here in the laryngeal vestibule, it's called as penetration. If it goes into the trachea, it's called as aspiration. There's a scale called as Pascal to classify that accordingly. But all of us can do a diet test, put a valve, and do a fluoroscopy study there. Train one of your resident and of your swallow therapist to do it. You can countersign the report. On basis of this, you can remove most of tracheostomy and most of Rayleigh's tube or PEC tubes. Those patients do a lot of involved in the posterior brain where swallow is involved. There's a technology called as vital stim. This is not electrical stimulation. This is neuromuscular stimulation of the pharyngeal muscles while doing so. It's helped to strengthen the muscles while doing swallow therapy. It helps in decannulation, even post decannulation, people who have impaired swallow because of pharyngeal muscle weakness. It's a good thing to add to your swallow therapy. So you can follow a simple protocol. You can first deflate the cuff, 24 hours cuff deflation. You can block the tube, block for 24 hours. You can manage blockage. There is no stridor. There is no aspiration. You can even check their expiratory flow rate. There's a simple flow rate machine available. It's more than 110. You can safely decannulate most of your patients with TBI. Then come music therapy, another low-cost intervention. Music therapy is beneficial for building plasticity because it affects multiple parts of the brain. It's a multi-sensory network stimulation, and it improves the auditory stimuli. And you can have a better picture of their whole concept when they give music as a stimulation than giving normal therapy alone. We do it for most of our patients. We have a separate music therapist, a separate music therapy functional room with us. This guy, you can see with TBI, is very aggressive, doesn't speak at all. A simple recital of a he's calmed down, he's trying to speak. None of our therapists are able to communicate. These music therapists can make him speak because music is a multisensory stimulation to the brain. That's a very low-cost intervention. You can train the families for that. One of our studies of patients with non-progressive brain disorders, those who are in VS and MCS stage, and we have shown that the coma scale as well as the CRS scale is better in patients who get additional music therapy with inpatient rehab. Early mobilization, Dr. Gupta spoke about it. Always remember, when not to mobilize, guidelines are available now. Maybe more than 180, GCS less than 8, saturation less than 94, heart rate more than 100, severe neglect. These are called as NICE guidelines, available everywhere, free on the internet. You can just take it from there. The most important concept is early verticality, because we are humans. We walk on. We have to make a person stand as soon as possible on a tilt table. It's a big stimulation to the brain. There are also systems available within FES inbuilt in the tilt table. You can put it in the IC, you can prevent postural drop. It can start standing very, very early. If they can stand, you have to make them to take steps. There are multiple technologies available now. body weight support, posturography, FES, neurofeedback, mental practice, mirror, virtual reality. But most commonly used systems are a body weight support system. You can use it on a treadmill or on the overground. Both are possible. Or robotic systems. This is Locomat, very commonly used. So what it does, this is a robot to make a person walk on a treadmill with the body weight support with the feedback in front of you. Feedback can be a graphical representation of the movement you are gaining or augmented feedback with virtual reality. So you can actually play a game on your. This is not passive walking. When people have no power in the beginning, it's passive. When they start gaining movement, it is active assistive walking. So we have two Locomat now with us. On day one, patient is made to first walk in the air. It's called as safe. Any person who GCS is more than 9, one has a no postural drop of blood pressure on tail table, be it hemiparacord, doesn't matter, tracheostomy doesn't matter. No postural drop, stable hemodynamics, head neck control can be made to walk. First day on safe walking, then they can do that. Called as nice walking on the treadmill. So robot makes you walk on a treadmill with a visual feedback. So it's a big solution to patients in the acute to subacute stage. If they can do that and they are conscious, they can see the power they're gaining in the biofeedback mode, hip, knee, what power they're getting, right, left. Those who are even conscious, those well, you can play a game with the virtual reality while walking. Also do the cognitive functions at that time. So in stroke data is available. Cochrane even say that 1 in 5 stroke patients who could not have walked by any other means can walk if you start training on robotics in the subacute stage. And it's only useful for non-ambulatory patients. Don't use it much for ambulatory patients, will not help at all. In TBI, one of our studies now of about 35 patients who were able to stand on tilt table, age 33 years, who got Locomat training along with the conventional therapy, you can see the FAC levels have changed in about 50 to 48% of patients. Level 1, level 2. Even Fugger-Meyer's scale for lower extremity has changed in about 65% of patients. It's a good thing to add in patients who are fit for training on robotics. Same way, people who are conscious in the first few weeks have primarily motor weakness and can engage in a game. Remember, God has made hand not to exercise but to do a functional task. So we can do a task-specific training 1,000 times in 30 minutes. Not possible with the help of manual therapy because there's no power in the hand. This robotics helps at that time. There are 3 machines. It's called as army of power. When there is no power in the upper limb, robotic will help first in the passive mode, then active assistive mode to use your hand to cut an apple, play a game, or drive a car. And then same person, if you can see gaining power, it comes to army of spring, which works mainly on the forearm in the elbow function. And then with only wrist and hand in the system called as Amadio. So robotic systems will help to improve the motor activity, motor control, they help in getting some power. Always combine this with conventional therapy so they can regain, learn a new function. Again, 32 patients who are managed with robotic assisted for upper limb along with conventional therapy. You can say Barthel index more than 10, change in about 83%, 93% of patients. In Fugger-Meyer, upper extremity has changed significantly in about 80% of patients. It definitely helps. Then people who have significant spasticity, we have to add botulinum toxin. Now technology has helped. Like this person has a stiff knee equinus gait. We plan to give botulinum toxin in his gastrocnemius and rectus. Now we used to do it blind earlier. Now ultrasound helps. Why? If you see here, this is gastrocnemius, middle head, bigger head, and the little head, and in center there's nothing. So it's very superficial muscle. If you give it blind, it mostly actually go into the soleus. So ultrasound helps to target your injection, one in the appropriate site in the appropriate muscle. Second, appropriate site in the muscle. You can give in the main bulk of the muscle in bank center, the maximum motor units are available. This is the middle head of the gastrocnemius, which plateaus here. And this all is soleus actually. You see in center, there is no gastrocnemius in the center. This is medial head. and multiplex, only one prick is required in one muscle because we are giving it with the guide. You see there's no gastrocnemius in the center. There's a smaller lateral head. You give bang into the center of the lateral head. The maximum motor units available. It helps reduce number of injections, target the injections better, and evidence says that you can reduce dose by about 20% if you give with the ultrasound guidance. Same person you see at 3 weeks post, he can bend his knee, the stick is out. It's a good medication to treat patient with spasticity along with conventional therapy. Another person with, because he can't open his hand with the initial lag. And even if he opens that, this is maximum possible. The FDS, the FDP, the FPL, the FPB, electropolysis, all are tight. And they give botulinum toxin ultrasound guided in his first 3 digits of FDS, FDP, FPL, FPB, electropolysis. We also use some xylocaine along with that to reduce the cost of overall injection. And then you can see here, we can even give one slip. This person has first 2 slips more than the next 2 slips. So you give it blind, you will give it in all the slips. So try to use ultrasound or EMG, which you're comfortable with. And you can actually give slip by slip in the FDS or FD, very specifically. You can see each slip, we're giving it slip by slip wise. This same person had post injections about a couple of weeks. You can see the spasticity is less, is able to do a training. Last is neural stimulation. Remember, there are 4 types of stimulation. We're talking about non-invasive stimulation. One is peripheral nerve stimulation. One is repetitive TMS or TDCS, a dorsal column stimulation to the spinal region, or a deep brain stimulation. So there are 4 types. First, PNS is given by stimulating a tibial nerve or a median nerve. RTMS or RTDCS is done on the skull. Dorsal stimulation is done on the spinal cord to stimulate the afferent pathways to the brain. And DBS is putting electrodes in the brain, in the basal ganglia to stimulate the arousal or motor pathways. Now, if you do repetitive median nerve stimulation, there are studies to show if you give it for at least 4 to 6 weeks in patients with VS and MCS, it helps. And it's a very simple way of doing it bedside. It's conventional therapy. Second is RTMS and TDCS. There's some evidence to show it helps, but still very small case studies are available. In the acute subacute stage, there are studies to show cognitive, speech, and motor deficits in stroke and TBI and chronic stage with RTD but TDCS. But in acute subacute stage for arousal, very few studies are available now. Then DBS is coming up in a big way. You can see patients who got DBS in VS or MCS. It helps. Now guidelines, now this summarizes everything. In first 4 to 6 weeks TBI, we should use amantadine within first week. Give for at least 6 weeks, combined with median nerve stimulation or somatosensory stimulation. Median nerve stimulation start within weeks in the ICU, combined with drugs, especially amantadine, as well as somatosensory stimulation. Somatosensory stimulation again start within first few weeks. Alternatively, HBO. Right now, anti-efficacy, but trials are coming, and it will be a big thing in the next 5 years, especially in acute subacute stage to improve arousal. These patients with VS and MCS stage. DBS in first 6 months, patient will not respond to a combination of pharmacology, nerve stimulation, somatosensory stimulation therapy. People who are MCS are good candidates for DBS. And in more than 6 months, DBS can help people with VS to some extent. RTMS or TDCS, very weak evidence right now. DCS stimulation, unclear efficacy. What you have to do in first few 6 months is significant therapy, multimodality stimulation, median nerve stimulation, amantadine, add HBOT, make them walk if you have robotics. Post 6 months, if they are MCS, DBS can help with the current evidence. We can summarize just few cases. This lady had a bad involvement. You can see in the functional MRI. These are functional MRI for somatosensory area, supplementary areas. You can see with intensive therapy, we're able to stimulate the supplementary area to take a function. This lady is able to take steps, discharge. This is FDG PET scan. You can see left ventricle involved. But this guy is able to speak, talk, and eat. This is a discharge. And it actually 4 years independent now. Another guy, nothing in the left brain, you see here, but at 1 year he is like that. Another massive involvement in the stroke actually. ACM is completely gone is at this. So we can summarize by saying that we all know we can reperfuse the brain in first few hours. In a stroke, by administration of IV TPA or by removing a clot, thromboaspiration, or a TBI by decompressive craniectomy, we all know. We know that in first few weeks, swelling comes down, some changes happen, then dies down by 3 months. That's why we are saying in community or in even medical community, कि 3 months के बाद कुछ नहीं होता है. Because we don't know. We have never tried intensive therapy for them. And we label them at VS or PVS at 3 months, which is wrong actually. If you start intensive training, intensive therapy, multimodality sensory stimulation, HBOT, robotics, medication, median of submission, if you can do simple thing, you get something called as training induced organization. It doesn't die down very, very early. It's a good thing to start in first few weeks, be it stroke or TBI, and try for at least next 3 to 6 months to change them for life. So conclusion, we should be able to prevent, recognize, and treat medical complications. Patient can do therapy, otherwise they will be lying in bed doing nothing. Second, multimodality sensory stimulation is a low-cost intervention and is more effective if done for short span multiple times daily. If you try amantadine trial in all patients with VS and MCS, do proper tracheostomy care, use decannulation protocol. You can decannulate most of the patients even in VS and MCS stage also. So long-term cost of care is less at home. HBOT is effective if combined with neuro rehab. Evidence is increasing now. Music therapy is a very effective tool, low-cost tool to improve communication arousal in these patients. Early mobilization is very, very important. You can try training on robotic assistance in suitable candidates to get mobility back. Ultrasound guidance helps to improve outcomes of bottom toxin injection for tone management. And neural stimulation, especially median nerve stimulation, will come up in a big way in the next few months or years. It's a low-cost initiative again. An appropriate candidate with MCS can be tried on DBS more than 6 months. So always remember, rehab is not disability management. That leads to further learn non-use. So patients, we only focus on what patient cannot do and treat that, which cause further learn non-use. What you have to do is treat the impairment, prevent learn non-use, train them for functional deficit to get more motor, language, speech recovery in long term. Thank you very much.
Thank you, sir. Thank you, sir, for this wonderful speech. It basically cleared all doubts about acute neurorehabilitation. And we are taking few questions now for the previous 5 speeches. I found there is one question by Dr. Gaurav Gomez, probably for Dr. Anupam Gupta, sir. Sir, in the study using multiple neurostimulants, did the mention any precautions or increased incidence of side effects? That is his question.
We know the adverse effects of all the medication. In this particular study, what they mentioned as adverse effect, I have not gone.
Okay. Any other question from the audience? Maybe put on the chat box or live audience. Any questions? Okay. So it is not only about machines, because it is the man ultimately who is behind the machines that is very important. Recently, I had a talk with a physiatrist in a South Indian city. He had purchased a robotics machine for neurorehabilitation of stroke patients and spinal cord injury patients and traumatic brain injury patients. He got success with that. He got financial success, commercial success with that machine. And he took care of the other factors that could complicate putting the patient on the robot, like managing the contracture, managing the spasticity, managing other cognitive issues before putting the patient on the robots. Seeing him, some people started copying that thing and purchased that robot, which costs in the crores, but they couldn't find that commercial success because they forgot that something is needed before putting the patient on the machine. So now I would request Professor S.L. Yadav sir, because Abhishek Srivastava sir is not physically present here. So I would request Professor S.L. Yadav sir to hand over the memento intended for Abhishek Srivastava sir to Anupam Gupta sir who will take it on behalf of Abhishek Srivastava, sir.
Thank
Thank
you,
you,
thank you,
Srivastava,
thank
sir.
you, thank you, thank you. Thank you. यदि उसको कुरियर कर देना.
Sir, you will also get the welcome hamper where there is a interesting calendar about power of brain. I think that will be interesting for you.
Thank you, Jaideep. Thank you very much.
Thank you, sir, for gracing our program. And now we go on to the next presentation
I'm
by
sorry.
Dr.
I'm sorry I couldn't come because we have ethics committee meeting today and I have a DNP as a presentation there, so I couldn't come because of that. I'm sorry.
No issues, sir. Anyhow, you have gave a comprehensive lecture, and we will be very happy if you can share the slide with our postgraduate students and others those who have engaged in the program. That will be very helpful for everyone. So now we go on to the next part of the program, that is presentation by Dr. Koustubh Chakrabarty. Kindly run the CV slide. Koustubh Chakrabarty, sir, is MD PMR and DNB PMR. MD PMR from IPGMR Kolkata. And he is currently attached with PLS Hospitex Hospital and Research Center, Kolkata. He is the associate editor of the St. John's Handbook of Physical Medicine and Rehabilitation. He is also the editor of News Bulletin of the Indian Association of PMR. He is the recipient of Dadichi Award for Best Overall Speaker in IAPMRC, IAPMR Con on 2007, which is a very prestigious award reserved for the single brightest presenter. And his innovation areas and interest areas include everything, including neurogenic bladder, neurorehabilitation, and pain management and rheumatology also. So now over to Koustubh Chakrabarty sir to to start his presentation about bladder rehabilitation after brain injury, the recent advances. Dr. Koustubh Chakrabarty sir.
Okay. After this wonderful multi-modality sensory presentation by Dr. Abhishek Srivastava, it's indeed a challenge to keep all your attention. Yeah, okay, Casey, here, this one. So first of all, I'd like to thank Dr. Jaideep Nandi, Dr. Raunak, Dr. Shushil for hosting us and giving us this opportunity to share our thoughts. And a warm welcome to all the audience who are present over here as well as virtually. So I'll be speaking a few things about bladder rehabilitation following traumatic brain injury and mentioning a few things on the recent advances. Before I go, I'd like to extend my grateful thanks to my colleagues, Dr. Rajendra Prasad Ray, who's a consultant urologist at my hospital, Dr. Prasad Krishnan, who's a consultant neurosurgeon, as well as my dear friend, Dr. Srikumar from AIIMS New Delhi. He's an additional professor for helping me prepare this presentation. The bladder is a unique organ. Most of the function is autonomous, but this is under sensory control. More than the bowel also, we have the power to decide when we shall evacuate the bladder, and even in the midst of evacuation, we have the power to stop it. So we shall be covering a bit about the innervation of bladder, mechanism of the normal function, what happens after TBI, what's the conventional ways where bladder rehab is done, and some newer techniques that are there. Some afferents from the bladder come down to the pelvic and the pelvic floor, come to the dorsal and sacral spinal cords, where they form a reflex arc, and efferents from there, they go back to the bladder, but this portion is under control of our brain because the descending tracts from the periaqueductal gray matter and the pontine micturition center, they synergize the bladder and sphincter action, making our voluntary control possible. We shall understand this innervation with the help of an analogy with the humble cistern. We know that the filling of our common cistern in the toilet is automatic. So it involves the autonomous nervous system mediated by the sympathetic portion, which is the hypogastric nerves, D10 to L3, and the receptors involved are the alpha receptors, which are present in the trigone, bladder neck, and urethra, whose contraction would lead to contraction of the bladder neck and the urethra, not of the trigone. In addition, throughout the detrusor muscle, there are beta 3 and also beta 2 receptors present. Their stimulation by the sympathetic system would result in relaxation of the detrusor muscle, which would allow for filling of the bladder. So, if we want to memorize, we can say sympathetics store. In addition, helping in the continence is our voluntary control over the external urinary sphincter supplied by the somatic nerves from S2, S3, S4 via the pudendal nerve, which helps to maintain continence. Now comes the voiding phase. Here, just as in a cistern, we have to push down on the lever. It's our voluntary control in adults that we have to exert to micturate. This is mediated by the parasympathetic system through the pelvic nerves, S2 to S4. The receptors involved are the muscarinic receptors, M2 and M3, present mainly in the detrusor muscle, as also in the trigone, bladder neck, and urethra. Their stimulation will cause contraction of the detrusor. However, in the previous slide, we have said that a sympathetic stimulation actually causes contraction of the bladder neck. So the system is such that immediately before the detrusor starts contracting, there is a reflex inhibition of the sympathetic system, giving rise to relaxation of the bladder neck just prior to when the detrusor starts contracting, and this causes a low pressure system to develop in the bladder, preventing upper tract damage. So if we have to memorize again, we can say that parasympathetics helps us to P for P. Apart from that, these nerves also carry some stimuli such as bladder wall tension, bladder mucosal nociception, as well as urethral mucosal sensation. If we considered howsoever number of times we go to the washroom to micturate, it won't be more than just a few minutes throughout the 24 hours. So for a major portion of the 24 hours, our bladder essentially has a storage function. And it is that storage function that is hampered primarily in traumatic brain injury, where along with bladder, there will be bowel dysfunction, and the early incidence is nearly 62% of the patients. The patterns involved are there's an uninhibited overactive bladder with poor sensation of fullness and impaired sphincter control. Traumatic brain injury will give rise to a detrusor hyperreflexia without appreciable detrusor sphincter dyssynergia, and I shall be concentrating on this part of the bladder management. As we know, it's typically a hyperactive neurogenic bladder where the volume is reduced, but it empties completely, leaving a very normal post-void residue. Rarely there might be urinary retention. It may be due to DSD, but we also need to rule out medication side effects, especially anticholinergics, benign hyperplasia of the prostate, or urinary tract stones before arriving at a diagnosis of a neurogenic induced bladder outlet obstruction. Urinary tract infection is the most dreaded complication and most common, and we shall spend 2 slides on how to prevent it. In addition, there will be incontinence, bladder stones or bladder cancer. Vesicourethral reflux might be there, leading to upper tract damage such as hydroureter, hydronephrosis. Renal calculi and dysfunction may also result, and we must not forget autonomic dysreflexia. Few tips on how to prevent UTIs. Number 1, keep the bladder as empty as possible and restrict intake of fluids 2 hours prior to bedtime so that there's not a lot of urine accumulated during the time when the patient is sleeping. The perineum needs to be kept clean, especially in those who have a fecal incontinence, to prevent contamination, And also constipation needs to be taken care of. Patients with indwelling catheters needs to have their catheters cleaned daily, at least by water, if not by a mild soap and water, especially near the tip, to prevent colonization of the bacteria, which might then move up and cause UTI. Encourage regular change of catheters. If it's a siliconized rubber catheter, then maybe at intervals of 1 month. And for pure silicone catheters, it's longer, maybe 3 or 4 months. Type 2 diabetes mellitus patients may be taking SGLT2 inhibitors such as dapagliflozin, empagliflozin or canagliflozin. So they cause glycosuria. This increases the chances of genital infections and UTIs. So we have to talk to our endocrinology colleagues that whether it's possible to substitute those drugs. Similarly, sitagliptin has been found to have a higher incidence of UTI. Acidification of the bladder may prevent bacterial growth. Cranberry juice has been extensively studied in Western literature. There's some controversy whether we should use it in patients who are taking coumarin derivatives such as warfarin, because the INR seems to increase. So there are papers for and against the same. But what's available in India is our common dahi. The lactobacillus over there prevents E. coli from growing in the urethra, and there's anecdotal evidence to suggest that traumatic brain injuries who are capable of accepting food by mouth, since curd forms an integral part of most of the Indian diets, they have a lesser incidence of UTI than those who are fed by a nasogastric tube. Also, vitamin C capsules combined with hexamine hippurate, they acidify the urine and do prevent UTI, and also they take care of any phosphate calculi that might be formed in the bladder. Our goals of rehab would be to increase storage and achieve social continence, as well as improved quality of life through the lesser number of times the patient has leakages or is forced to go to the washroom. And the secondary goal is to ensure the complete emptying of the bladder regularly in order to reduce the intravesical pressure, improve blood circulation in the bladder wall, causing the bladder mucous membrane to become more resistant to bacterial infection, and reducing upper tract, that is kidney and ureter damage. The conventional management consists of a few investigations as well as interventions. And the first investigation per se is we shall ask the patient and his family members to maintain a bladder diary for at least the past 3 days. This consists of the intake as well as the output, timings, how much quantity has been intaken, what is the quantity of leak at which timing, and how much has he voided voluntarily. This would give us an idea whether the patient is taking too much of fluid, or maybe after meals he or she is used to take too much of fluid, which is causing incontinence, but at other times he is continent. We might even do a urine RE, and a culture sensitivity might be done, a USG, KUB, pre and post void, and a simple uroflowmetry. And we might measure serum creatinine to get an idea of the renal function. A small caveat is that if the patient is too much cachectic, the creatinine value will be falsely low. So if we are suspecting a urinary kidney dysfunction, we should do a serial creatinine and see whether it's rising or not. Behavioral and lifestyle modification is the first intervention, and this may be augmented by medications. If they do not work, usually we do a urodynamic study and then move on to the next one, such as an intravesical Botox, botulinum toxin type A injection, if the patient can afford, or a urinary catheter, which is our last resort sort of, or it's not come over here, maybe due to the difference in the computers, an augmentation cystoileoplasty. So what are the behavioral and lifestyle modifications? We should correct the fluid intake, as I've said, restrict water prior to bedtime, review what medications the patient is getting. If he's getting diuretics, we shall ask our general medicine colleague or our cardiologist colleague whether that can be substituted with some other antihypertensive. The patient should be asked to restrict or stop smoking, decrease or stop the intake of diuretic fluids such as tea, coffee, carbonated beverages, and also some anecdotal evidence for sugary or spicy food. Kegel's exercises can be prescribed which will help in strengthening the pelvic floor muscles and possibly achieve more continence. And then from the diary, we shall see what's the minimum interval after which the patient starts leaking. We shall start with that and set a serial alarm on his mobile and ask the patient that no matter what, you do not void before the alarm sounds. Gradually, by increasing this interval, say 5 minutes every 3 days, we shall try to achieve a time, say every 2 hours, where a social continence is possible. This is called urge inhibition. The commonly used medications are the anticholinergics, which shall block the muscarinic receptors and help in relaxation of the detrusor, providing for more feeling, as well as the tricyclic antidepressants, which have the similar role. However, most of the older anticholinergics are associated with cognitive disorders, especially in a TBI patient, such as oxybutynin. The newer ones, such as solifenacin, darifenacin, trospium, are better tolerated. TCADs in addition produce sedation, so that might prove detrimental to our TBI patients. Mirabegron has come up. It's the first approved beta-3 agonist, which we have seen causes relaxation of the detrusor. Literature says that it works equally well as anticholinergics, but my practical experience from especially the urology colleague has been that it does not. A combination of mirabegron with an anticholinergic is available, and he prefers that rather than using mirabegron alone. The only significant side effect is that it might cause hypertension, along with some other side effects such as dry mouth, UTIs, URTIs, joint pains. The usual dose is 25 milligram OD, and a steady state is reached in around 8 weeks. We might increase that to 50 milligram if 25 milligram is not working. However, this behavioral modification suffers from the fact that many of our urban slums are like this. There may be a single room where 3 generations of the family are staying. The toilet is shared and it's far away. There might be a queue in front of toilet. So this urge inhibition type of control will be very difficult due to lack of privacy, also lack of family member support. They have to work because the main bread earner is now injured. So there might not be somebody to take the person to the toilet or give him the urinal at that time. So in that situation, we have no other option but for the poor patient to go in for the indwelling catheter. But for those who can afford or are covered by some sort of social insurance or their workplace insurance, we might try intravesical botulinum toxin type A, where around 200 units are injected into the bladder at 30 different sites, maybe 1 centimeter apart. It works well. The only drawback is it has to be repeated every 4 to 6 months. And of course, the cost issue is there. Indwelling catheter during acute management is very helpful to measure the output as well as to de-stress the nerves. However, in long term, it benefits the caregiver more than the patient. But in places where the caregiver is not available, maybe he or she has to go out to work, that becomes our modality of compulsion, not of choice. The additional complications with indwelling catheter are urethral complications such as urethritis, strictures, false passage, erosion, fistula, maybe bladder stones and cancer, pain and discomfort, epididymis and scrotal abscess. Also, it prevents any sexual activity, which is an unaddressed need of our population. We generally do not like to talk about it, and the patients cannot vent out that unexplained need. It also prevents social interaction. It's very difficult to go to somebody, a relative's place with a urobag in place. Augmentation cystoplasty is a last resort where a part of the ileum is taken and then surgically attached to the detrusor for a greater bladder volume. It has the advantages of being permanent, so you do not need repeat injections such as in botulinum toxin. The quality of patients of surgery is higher and might be cost effective in the long run. However, since we are taking a part of the gut, it's not detrusor muscle, it cannot contract. So there might be an issue of insufficient evacuation. So you might need to prescribe CIC for these patients. For the newer and upcoming methods, what I found that most of the literature was on spinal cord injury model. So For traumatic brain injury, where storage is the main issue, not so much the evacuation, the literature was scanty. I've tried to include those that have included, apart from spinal cord injury, some other causes of neurogenic bladder as well, such as Parkinsonism, multiple sclerosis, where there might be some benefit for the storage function. I'd also like to touch upon these cyclical antibiotics. Traditionally, we are taught that do not treat asymptomatic bacteriuria, but some French investigators have turned that on its head for patients who had recurrent UTI. They were actually doing CIC, and for UTI of more than 4 times a year, they found an antibiogram, chose these 4 antibiotics. For individual patients, they chose 2, which were most suitable for those patients. On Sunday of first week, they gave antibiotic A. The second Sunday, they gave antibiotic B. Third Sunday, they gave antibiotic A again. Fourth Sunday, antibiotic B, and so on for 6 months. So weekly, 1 day only, they were giving these alternate antibiotics. And at the end of 6 months, they found that not only there was a decrease in the number of febrile UTIs, as well as hospitalizations and antibiotic consumption, there was no emergence of bacterial resistance either in the urinary flora or intestinal or nasal microbioflora. Electrical stimulation has been extensively used for neurogenic bladder management, and it can be at any level in this reflex arc, can be here in the sacral anterior root stimulation, can be sacral neural stimulation, can be in the posterior tibial nerve, can also be proximal. But as I've said, most of the studies are in the spinal cord injury model. Years ago, in 1976, the first time it happened in a human, Brindley did this procedure where he did a laminectomy and implanted the cords on S3 to S5 anterior nerve roots. There was a passive receiver which was implanted in the anterior abdominal wall, and this stimulator was given. With this, he was able to achieve an on-demand bladder contraction and an efficient voiding. He combined this with a posterior rhizotomy, sacrificing the posterior roots, which achieved a greater bladder capacity, compliance of the detrusor, improved continence of the bladder, and a decreased post-void residue at the cost of irreversibly eliminating the reflex erection, reflex micturition, and any remaining pelvic sensation. The sacral nerve stimulation by the proprietary Interstim made by Medtronic company eliminates the need for laminectomy. First, a test stimulation is made on the sensory afferents that are coming in to the sacral cord, which will stimulate the reflex arc, and they actually got a benefit for the treatment of urge urinary incontinence and retention, and only those patients who are successful in the test dose, they get implanted this pacemaker-like thing inside their skin. And they have said that overactive bladder has had a long-term improvement with this procedure. Percutaneous tibial nerve stimulation. So by inserting a needle into the posterior tibial nerve, a little above the level of the medial malleolus, it has been shown that overactive bladder urgency, frequency, and incontinence has improved. It's OPD based. The stimulation is delivered for 30 minutes once a week for 12 weeks, and benefits have been reported. But then some big corporations in the US said, why have the physiatrist chap get all the money for 12 visits? Why not do something ourselves that will save the patient 12 physician visit, and also it will be a one-time solution. So this eCoin came up. So this is an implanted stimulator at the posterior tibial nerve, which can be programmed externally by this, such as a pacemaker is being programmed. And they have said that 26% of patients of overactive bladder have benefited in 12 months. Despite this low number, it has received an FDA approval. Now, as physiatrists, we are doing percutaneous things. I was just thinking about whether we can do something transcutaneous, which we instruct our physiotherapists to do day and night. So I found a paper that has studied in Parkinson's patients this transcutaneous tibial nerve stimulation which has achieved a reduction in nighttime urinary frequency, urgency, urge incontinence, as well as use of diapers. Even in 30-day follow-up following this stimulation program and 90-day, they have reported a 50% and a 33% carryover benefit in this stimulation as well in the Parkinsonian model. TESCON is something which stimulates the cord. There are adhesive electrodes which are applied on the interspinous ligaments between T11 and L1, and the anodes are applied on the iliac crests. 3 sessions for 8 weeks, 3 sessions per week for 8 weeks are given for 90 minutes, and an alternating pulse of a high frequency current 10 kilohertz along with a low frequency current of 30 hertz are given with a pulse width of 1 millisecond, and this has decreased detrusor overactivity. It has improved compliance and enhanced LUT sensation. This has been studied in CVA, spinal cord injury, multiple sclerosis, as well as in idiopathic overactive bladder models. Finally, in the future, maybe we'll get this device. This is still in the feline model. It's been studied in cats only. That is, an intelligent chip is implanted on the detrusor muscle that can sense its feeling, an increase in detrusor pressure, and gives a stimulation so to cause the detrusor to contract and achieve a perfect emptying of the bladder. So the take-home message will be that neurogenic bladder after TBI consists of an overactive bladder with reduced capacity and a generally low post-void residue rate. Our goal is to increase the bladder volume and reduce the incontinence to improve the patient's personal and social life. And we have a range of options. Depending upon the patient's needs, we shall choose one or more to tailor our rehab management program for it. Thank you very much for the patient listening.
Thank you, Koustubh sir, for your nice presentation, which dealt with neurogenic bladder in its full depth. Now I request Dr. Pritam Vasnik sir to hand over the memento to Dr. Koustubh Chakrabarty sir. Memento as well as certificate and the gift hamper. Dr. Pritam Vasnik is a pillar of our general medicine department, and Dr. Koustubh Chakrabarty is CV slide. Good to hear the name of Dr. Rajen Roy, who is a colleague of you. He is also my friend during my PG days. For 2 years, we stayed in the same hostel, IPGMR hostel. So now we go on to the next presentation. That is by Dr. Navin B. Prakash, who is working in AIIMS. And he will be talking about neuroradiological correlation in brain injury and the rehabilitation perspective. Dr. Navin B. Prakash is an MD PMR student from PMR graduate from SMS Medical College, Jaipur. And regarding his work experience, he had worked as an assistant professor in Department of PMR CMC Vellore since 2013 to 2018. Then he worked as assistant professor in the Department of PMR in St. John's Medical College, Bengaluru since 2018 to 19, and currently is attached to the Department of Neurological Rehabilitation, AIIMS. His interests include rehabilitation of individuals with spinal cord injury, traumatic brain injury, TBI, and amputation. He will be talking about neuroradiological correlation in brain injury, the rehabilitation perspective. Over to you, sir. Dr. Navin B. Prakash.
Thank you. At the outset, I'd like to thank the organizing committee for giving me this opportunity, especially Dr. Jaideep. So I'll be speaking about the role of neuroimaging, primarily CT and MRI, as we know in traumatic brain injury. So how does MRI work? I'll be speaking in 4 major domains, that is the role of imaging in monitoring, diagnosis, assessment of complications, advances, and prognosis. These are the 4 domains I'll be speaking on. And So the focus is CT and MRI. How does MRI work? Basically, we have ions in the protons in water. So we have a lot of water in the body, and the protons are like small magnets, and we expose these magnets to a magnetic field. Depending on the tissue involved, there are changes. So the various parameters can be used. That is the direction of the field, then the relaxation time, and other parameters can be changed, and we get different sequences. So this is a T1 sequence, as you all know. So where the gray matter appears gray and the white matter appears white, CSF is black. In a T2, it's near inverse, where the outer gray matter appears white and the inner matter is appearing slightish gray. The CSF is white. In flare, which is a fluid attenuated sequence, the CSF gets attenuated. It's similar to a T2. The CSF appears black. So the gradient echo sequencing is similar to a T2, but it is very sensitive for microbleeds. So this is a scan which is showing the EDH in the left temporal lobe, and usually it is associated with injury to the skull as well. So here we can see a small SDH, but on the axial section we are not able to define the extent. So it's been recommended, although we do not routinely do it, to do a coronal imaging as well, where we can appreciate the extent of the SDH. So there's a small contusion in the right temporal lobe, anterior part has a hyper density in the CT. So on the left is an image of a CT from a young male, and we can see that it's normal, whereas the MRI on the right side is able to pick a small contusion in the parietal lobe. So again, a young male after RTA and memory loss. So we have 3 sequences of the MRI, T1, T2 and flare. T1 is good for appreciating normal anatomy. The remaining sequences appreciate pathology, and these are normal. Whereas if we see the susceptibility weighted imaging, we can see small hypodensities which are hemorrhages. These are microbleeds. If there are more than 3 microbleeds in different areas of the brain, then the terminology is diffuse axonal injury. If it is less than that, then it is traumatic axonal injury. So again, in monitoring and complications, so when do we do a repeat CT scan in mild TBI or concussion? So the indication is basically a neurological deterioration, delayed recovery, or persistent unexplained deficits. Other is if the criteria for diagnosis indicate that the scan has to be repeated. So this is important because doing routine imaging again and again can lead not only to increased radiation exposure, but also to lot of cost in terms of healthcare budget. So actually, how much does a repeat CT scan change management? So it's been observed that in all 3 groups is a meta-analysis. So mild TBI, moderate TBI and severe TBI, less than 0.05% of the patients after repeat scan actually change the management. So we have to choose the patients in whom we do the scan wisely. So in monitoring, we have to always look for any deterioration. And in the left, I have image with an EDH, and if you can see, the sulci are effaced and there is a herniation. So the basal cisterns are effaced here. We are not able to appreciate, and the tentorial herniation is there. And the middle image shows a SDH with compression of the ventricle, and the last image, the third one, is showing acute on chronic SDH, because we have 2 shades. One is hyperdensity and hypodensity with compression of the ventricle, and we see the midline shift. This is a subfalcine herniation. So we need to monitor patients. Any patient who is not improving according to expectation or who show new signs of deterioration, then imaging has to be repeated. So post-traumatic hydrocephalus is common and usually of the communicating type. So communicating because the CSF in the ventricles communicate with the subarachnoid space around the brain. And here we can see the ventricles are dilated in both the sections, and it's a communicating hydrocephalus. The other indication is that we can appreciate the sulci. They are not effaced. Whereas So in communicating hydrocephalus, it's important that it can become a normal pressure hydrocephalus. So patient may have ataxia, then dementia, incontinence, and other symptoms. So we need to keep that in mind. So the obstructive hydrocephalus usually presents with increased intracranial pressure, so nausea, vomiting, new onset deficits may occur. So we see the ventricles which are dilated, and it is not communicating with the subarachnoid space around the brain. So this requires probably urgent intervention from the neurosurgery team. So here again there are changes which occur in the brain over a period of time. Left side is T2 weighted image and T2 flare from at 4.5 months following injury. We see a small contusion in the anterior temporal lobe on the right side, and in the T2 flare also we can see a change. It is subtle, but at 2.5 years when we can see that this has progressed, and the flare imaging is showing gliosis and also atrophy. So chronic traumatic encephalopathy has been described in boxers and other athletes who have sustained more than 2 contusions, and this is a septum pellucidum which is called cavum septum pellucidum, which has 2 laminae, and this widening of this has been reported more in CTE, and when this extends posteriorly it's called the cavum septum vergae. So where we can see it posteriorly also, and the width of the cavum, the septum pellucidum is increased in chronic traumatic encephalopathy. So now we'll talk about the advances and research and prognosis. They all overlap one another, so combine them. So first is we all know diffuse axonal injury. There are 3 grades. Grade 1 has a better prognosis than grade 2. Grade 3 has the worst prognosis. So in grade 1 we can see small lesions on T2 images at the gray white matter junction. Similarly in the flare, and if we see the GRE, there are small bleeds. So GRE is very sensitive for micro bleeds, so you can see them as small hypointensities in the left image, and on diffusion imaging you can see a restricted diffusion. So in a grade 2, the splenium of the corpus callosum is usually involved. In addition, you can have anterior part of the corpus callosum, the thalamus, the internal capsules also being involved in the grade 2 diffuse axonal injury. So diffusion restriction can be seen in these regions. So a study was done to see in mild TBI what are the other associated factors which predict a poor outcome. So one was the presence of contusion, and the other was SDH when associated with mild TBI. You can see in the Glasgow outcome score, they have scored in the severe category, that is a GOS 3 or less score means a severe disability. So those who have associated contusion or SDH have poor prognosis as compared to others in complicated mild TBI. So in addition, the number of shearing lesions on MRI, the volume of these lesions, and also location of the lesion that's in the corpus callosum has been associated with the increased score on the modified Rankin scale on follow-up. So increased stage in the MRS implicates that there is more disability. So as the number of and volume of lesions increase, or the lesion is in the corpus callosum, then disability increases. So we have the susceptibility weighted imaging, which uses the principle of different tissues have different susceptibility to the magnetic effect. So this is used, it is very sensitive for detecting microbleeds. As compared to a GRE, it is 3 to 6 times more sensitive in detecting small microbleeds. So it's very useful in diffuse axonal injury. So they have studied the number of microbleeds and seen its association with depression. And they found that if the number of microbleeds is more in the frontotemporal parietal regions, the susceptibility to develop depression is higher in these patients. And also the mean volume of the microbleeds has been assessed. And they found again this group with a higher volume of microbleeds in the FTP region have a greater propensity to develop depression with time. So diffusion tensor imaging, this we all know that we can see the tracts in it. It is something like you put a drop of ink on a wood, then the ink tends to diffuse along the grains, not against it. So similarly, the water in the brain, which is again water in terms of MRI is protons, the hydrogen ions tend to diffuse along the axon and not in other directions. This has been referred to as an asymmetry of motion normally. Asymmetry in the sense that flow is usually unilateral or unidirectional, thereby it's an asymmetry of motion. For this asymmetry, the terminology used in DTI is fractional anisotropy, which means normally there is asymmetry, so fractional anisotropy is high. So that is a normal in a control. So the study was done with measuring fractional anisotropy in 3 groups. The C is the control, green is mild injury, and MS is moderate or severe TBI. And they found by measuring the fractional anisotropy in all 3 groups in different regions of the brain, the corona radiata, the forceps major, corpus callosum, and also the thalamus, the moderate or severe injury have lesser fractional anisotropy as compared to the other groups, indicating that the asymmetry which is normally there is lost. That means the molecules tend to diffuse in other directions or there is a loss of integrity. So a study was done to see how in DTI using a 3 Tesla machine, how the damaged white matter structures, the number of damaged white matter structures and the cognitive testing, that is the cognitive reaction time, how they are related. So what they found is as the number of white matter structures damaged increase, the time to perform the cognitive reaction time increases with the number of white matter structure damage increasing. However, they found that the number of traumatic microbleeds on conventional MRI does not correlate with the cognitive performance. So they postulated that it is more important to assess the white matter damage than assessing the microbleed. So magnetic resonance spectroscopy is quite widely available, and a region of interest in the brain is taken and different molecules can be studied. So here the hypothesis is you have the molecules and there is a bond with the hydrogen atom, and depending on how this bond is, they respond differently to magnetic stimulation. Most commonly studied, there are 12 of these 6 are most commonly studied. So N-acetyl aspartate is an indicator of neuronal integrity, creatine is an indicator of the cellular metabolism, choline is an indicator of cell membrane integrity and repair. So this is how a spectroscopy looks. What has been most commonly studied is the ratio of N-acetyl aspartate to creatine or to choline. So in the study in 3 groups, that is those in vegetative state and those who came out of RAS, they came back from vegetative state to they regained awareness, and controls. In this group, 3 groups, if you see, the N-acetyl aspartate to creatine ratio is the lowest in the vegetative state group. In the group which came out, it is better as compared to the controls. Controls have the higher values. So this again is the same NAA to creat ratio, and this study is on concussion. So this is controls, they have a higher level of this ratio. So those who have a single concussion, they have a better value of NAA to creat than those who have double concussion. And as time goes by with improvement, this ratio is improving. So to say that in the same patient, you can repeat an MRS and assess the NAA to creat or choline. And if this is improving, it indirectly indicates that there is recovery within the brain parenchyma. So functional MRI can be done basically during rest, that is without any activity at all, or you can do a passive fMRI, that is you just give an auditory click or a visual stimulus, the patient need not do anything, or a task fMRI where the patient is instructed to do some motor imagery. So the basic principle is there is an increased neural activity, and a few seconds later there is an increase in local hemodynamic response. This leads to an increased oxyhemoglobin in relation to the amount of deoxyhemoglobin, and this leads to a reduction in the magnetic susceptibility of the local tissue, and this is called the BOLT, blood oxygen level dependent signal, which is used in the fMRI. So in this is, we are seeing three groups. One is control, one is a post-concussive syndrome, and one is moderate post-concussive syndrome. And they were given a verbal working memory task. And if you see in the controls, they are activating the anterior regions of the brain more. Whereas in the PCS, they are not able to activate the anterior regions more, and they are activating the posterior other areas for the brain for doing the same task. So this is two patients. Left is, both were clinically diagnosed with unresponsive wakefulness syndrome or vegetative state. So left and right, both are two patients. So we have four images, set of images. One is the FDG PET top row. Second row is the MRI in the resting phase. Third is the DTI, and fourth is the mental imagery fMRI. So if you see in the second patient as compared to the first, so you can see that there is more metabolism in the second patient in the FDG. On the resting state fMRI, there is more activity in the second patient. You can see more white matter tracts on the DTI, and also during the fMRI mental imagery, there is activity as compared to the patient on the patient 1. So this indicates that on neuroimaging, mostly this patient is having minimally conscious state. Although clinically the patient is in the vegetative state, mostly this patient is in a minimally conscious state. So perfusion imaging has mostly been studied in stroke. However, there is literature in traumatic brain injury that the perfusion is affected. So it can be done either with CT, where you use a contrast, or you do with an MRI without contrast. So if you see, we have a bleed, and then there is a perfusion deficit. That's the increased blue in the image, the lower image. And once this bleed is removed after treatment, you can see the perfusion has improved in the perfusion imaging. So now this is another set of images. The lower three images are perfusion images on admission. So at admission, there was reduced cerebral blood flow, this blue. There was increased regional mean transit time in the blood flow. And if you see the CT scan initially, it's a very small contusion. 24-hour CT later, the contusion has increased. If you see the 15-day image and you see the initial perfusion CT, what has evolved is nearly the same. So what they're hypothesizing is doing a perfusion imaging during the initial phase may help us decide in how the lesion is going to evolve over a period of time, and we can probably act earlier than what we would with routine imaging. SPECT again is easier than compared to PET. So there is a study in SPECT at baseline in mild TBI, and it has very good negative predictive value for neurocognitive outcomes. That is, in those with a normal SPECT at baseline, none of them go on to develop any neurocognitive deficits at 6 or 12 months post-injury. So again, SPECT has been used to decide treatment. We all know that methylphenidate has class 1 evidence for use in TBI, for attention especially. However, not all patients respond to it in the same way. So they studied why does this differ. So the hypothesis was in patients with a low dopamine level, it is better to use it than those who have a normal dopamine. So they calculated this caudate specific binding ratio by doing a SPECT, indicating that there is a lower transporter of the dopamine, and these two groups, they gave dopamine at admission. So one with a normal level, one with a low level, and you can see that the reaction time to cognitive testing is lower, means they are able to process information faster. This is at admission and at review also. The choice reaction time is better in the group with a lower level at admission. So to conclude, there is a lot of opportunity for research where we can collaborate and do more things in this field. The technology is becoming more and more available, and advances are becoming available to us. Machine learning, neural networks are coming up, and time may not be far away when neuroimage reporting is going to come along with these are the functional deficits expected for this patient, and we can tailor our rehab program based on that. I thank you all for your patient listening.
Thank you, Navin BP sir, for your nice presentation on neuroradiological correlation in brain injury. Now I request Dr. Koustubh Chakrabarty sir to felicitate Dr. Navin B. Prakash sir with a memento, certificate and gift hamper. That's really a nice presentation. Just after 1 week, within a few days, we are going to celebrate the 50th year of the formation of Indian Association of PMR. The Golden Jubilee Conference will be held in New Delhi. Sir is an important member, patron of that team. I will request all the online attendees of the conference, who are mostly physiatrists, to attend that conference, which will be a very good scientific fest. We all are sure about that. Now I will conclude the CME with a little vote of thanks for all the relevant persons and dignitaries and other staffs and other faculties who had helped us in reaching this position today. I would thank our Honorable Director Sir, Professor Nitin M. Nagarkar Sir. It can be rightly said that under his leadership, PMR is growing in entire central India, because he is both holding the AIIMS Raipur directorship as well as AIIMS Bhopal. Both are the two apex PMR departments at present in central India. There are no such departments in other medical colleges in this area. So it is under his guidance, under his leadership, under his vision. And mostly he had always been positive. He is a person who can extract the best out of you, and that also with leading by example. So I thank you, sir, for being a constant guide in our institute. I will also like to thank our Dean, sir, Professor S.P. Dhaneria, sir, who is Professor of Pharmacology as well as the Dean of our institute. And within a few days, he will be retiring. He has initially agreed to come, but due to some other examination-related priorities, he couldn't attend. But it was always very helpful and positive vibes that we get from him whenever we meet him. And he has always helped us in achieving whatever little we have achieved regarding starting MD, getting UG classes, getting MSc nursing classes. So I thank you, sir. I also thank the Deputy Medical Superintendents of our institute, Dr. Dibakar Sahu, Dr. Tridip Datta, Dr. Ramesh Chandrakar sir, for helping us in our administrative problems, whatever they are happening. They have always came up with some or other help, and thank you, sir. I also thank our Deputy Director Administration, Mr. Anshuman Gupta ji, for always helping us in our administrative issues and other issues, and also giving us very relevant and realistic tips as always. Financial advisor Agarwal sir is also very helpful, always resourceful, always gives a very practical tips, and always helps us in doing whatever activities we are doing. I will also thank our Senior Administrative Officer and Store Officer, Sita Ramuji, because we have always lots of procurement going on, or at least 35 purchase orders has been released in last 4 years, and that includes about 500 equipments. Most of them equipments are in prosthesis orthosis workshop. The next most will be in occupational therapy and physiotherapy. Then PMR doctors equipments were less but usually more expensive, like ultrasound machine and NCV machine. Now Gate Lab is coming up and virtuality. So thank you Sitaramuji for helping us in all those purchases, all those administrative problems. I also thank our Superintendent Engineer, Lieutenant Colonel Rajesh Singh ji, who has helped us in all the departmental related engineering works and electrical works, and various other projects are also coming up. So thank you, Rajesh ji, for your continuous help. Now coming to the department, I thank my colleague Dr. Ronak Kumar Singh, who has joined from Safdarjung, followed by AIIMS New Delhi in our department, and is always a very helpful hand. and the department become more lively with your presence. I also thank my senior residents, Dr. Sushil Kumar Nayak, Dr. Aradhana Shukla. Both of them had been a strong pillar of support in building our department, in tackling patient care, teaching PGs. I also thank our physiotherapist and multi-rehabilitation workers, Shalini Singhal, Snehanjali Jena in particular, because they had been the longest working in our department. Even before I joined, they had joined the department, and they had started the department under guidance of Professor Alok Kumar Agarwal of Orthopedics Department, who has also guided the department for very long period. And after that, I came and I took over the reign of PMR department from him. So they are the senior most physiotherapist, Shalini and Snehanjali. Then other four came: Manoj Bansal, Narsimalu, then Vijay Nagre and Ritwan Singh. So I thank all of them for being a continuous help, continuous support. I also thank our prosthetist orthotist, who is very energetic, Mr. Biresh Kumar, and he has also made about more than 60 prostheses and orthoses in our institute single-handedly, which is very rare to do single-handedly. In most of the institutes, there are 2 or 3 helping hands, but here he had done it single-handedly. So also thank my occupational therapist, Rahul Sharma, who has been continuous support in occupational therapy section, as well as also agreed to serve the COVID duties during the COVID pandemic, along with the physiotherapist. That is a very helpful attitude from him. Then I also thank my nursing officers. Mary Grace officer has been long standing serving our department with always graceful and always smiling. And also I thank my IPD nursing officers. Mukti Ekka, madam is the senior nursing officers. Then Sunita, Motilal, Jitendra, Sona and Urmila. They are the other nursing staffs who are serving in the IPD section, our 10-bedded PMR IPD. Then I also thank my departmental clerk, Mrs. Bijeta Singh, who has been continuously helping in since many years, and most of the work couldn't be done without her own efforts. So I also thank my hospital attendant, currently Navin, before that Ramesh, and also the other hospital attendants they had worked in our department. I also thank my research associate Rajkumar for helping us in organizing this program. Last but not the least, I will thank the AIIMS administration in helping in all our endeavors. I thank you all online attendees for gracing this occasion, sparing some time in this weekend. Thank you all. So with this, we conclude our CME. Thank you all.